universal health coverage in Nigeria, chairman of the education in the Americas, NAPSA. Chief host, Professor Cyril Usifo, President, Pharmaceutical Society of Nigeria. Host, Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Pfizer Pharmaceuticals, Greenlife Pharmaceuticals Limited, and NewHeights Pharma. Starts 9 a.m. prompt on Wednesday, 28 August 2024 at the PSN Lagos Secretariat, Ogudu, Lagos, for both physical and virtual attendees. Grand opening ceremony date Thursday 29 August 2024. Venue Providence Hotel, Obakijobi Way, Ikeja. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be streamed live on PharmaStream TV YouTube channel. Subscribe today for instant notifications when event goes live. Announcer Pharmacist Derek Osondo, Chairman, Planning Committee. The Pharmaceutical Society of Nigeria PSN Lagos State Branch presents the annual Pharmacy and Scientific Week 2024. Theme: The Imperatives of the March Towards Achieving Universal Health Coverage in Nigeria. Chairman of the occasion, Pharmacist Victor Afolabi, MD Wellness HMO. Keynote address, Pharmacist Kunle Tometi, FPSN, President of Nigeria Association of Pharmacists and Pharmaceutical Scientists in the Americas, NAPSA. Chief host, Professor Cyril Usifo, President, Pharmaceutical Society of Nigeria. Host, Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Pfizer Pharmaceuticals, Greenlife Pharmaceuticals Limited, and NewHeights Pharma. Starts 9 a.m. prompt on Wednesday, 28 August 2024 at the PSN Lagos Secretariat, Ogudu, Lagos, for both physical and virtual attendees. Grand opening ceremony date Thursday 29 August 2024. Venue Providence Hotel, Obakijobi Way, Ikeja. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be streamed live on PharmaStream TV YouTube channel. Subscribe today for instant notifications when event goes live. Announcer Pharmacist Derek Osondo, Chairman, Planning Committee.
I did promise that we will start this event at exactly 10 o'clock. Now it is 2 minutes to 10 o'clock. Let us start. What's it by your watch? 9:28. 10:28. All right. If you say it's 10:28, I will agree with you. I will agree with you. If you say it's 10:28, I will agree with you. I just checked now. I thought I had low sugar before, but now I think I can see clearly. The chairman, PSN Lagos State, pharmacist Oyekule Babaji MEW, please, can you lead your team of past chairmen and fellows of the society and fellows of the college to the front? This is not the front. This is the front. All right. We'll be having 3 classes today. Greenlife Pharmaceuticals Limited. Can we give them a round of applause? Pfizer Specialties and NewHeights. First, to shoot the gun will be Greenlife Pharmaceuticals Limited. And today, we have the product development manager / marketing manager for Greenlife, pharmacist Okolo Henry. Please, can you just stand up for recognition? Also in our midst is their guest speaker, a professor of tropical disease and consultant medical parasitologist. When you hear parasitologist, what comes to your mind easily in Nigeria? Okay. They say Prof is a parasitologist, but not a parasite. At the College of Medicine, University of Lagos, Idiaraba. Can we give a round of applause to Prof? Amongst so many titles and very long profile, I will end with this. That Prof serves in several boards and committees in both private and public sectors, nationally and internationally. He is the chair of the Malaria Operational Research Group, MOREG, of the National Malaria Elimination Program. And I'm very sure that with the presence of Prof today, malaria is gone. He's a member of the NAFDAC's Vaccine Advisory Committee and the Clinical Trials Committee, member steering committee for NTDs, that is, of the Federal Ministry of Health, among others, and also the Pioneer Director, Research and Innovation of the University of Lagos. He coordinates so many departments. In fact, the way I know, since I knew him, he has never slept. Join me in celebrating this easygoing and amiable professor of parasitology. His name is Professor Wellington Oyinbo.
Thank you, sir. Thank you, and good morning. So, first of all, I give the apologies. It's unusual for me to come a little late, but I had a little challenge this morning. So the chairman of PCN Lagos and the PSN, sorry, and then the past chairman and the executives, the members of management of PSN Lagos State, colleagues and ladies and gentlemen, thank you for the opportunity to be here this morning. Of course, thanks to Greenlife Pharma. I want to say that I've had the privilege of coming here a number of times. And then because I have done a sabbatical in one of the multinational pharma companies in Switzerland, I know what the pharma industry is. And I want to salute you all for continuing the classes. I've been here. This is just one of the easiest ways by which we can have the exchanges. Because the pharma industry is knowledge-driven, top knowledge-driven. And I see the promotion, I see the consolidation, I see the deepening of knowledge in all of these meetings, which is always very good. So I thank you, and I want to say that the sustenance should continue because we live by the updates. The updates are coming real fast, especially when it comes to organisms that causes diseases. We are talking about mpox now. We had a challenge of COVID. And then for malaria, we are having a lot of biological phenomena around the parasites, around the vectors, all developing resistance, all mutating, and all of these. And I answer an amen to the MC that we all join to kick off malaria and see how it looks like. Yeah. So thank you very much for the opportunity. And when I was looking at I'm sure the slide has been shared. So I was looking at the talk to give, and I tried to maintain the title, which was given to me, of the topic of the presentation. And new emerging threats of malaria, and resistance is in brackets. You can see in quotes, rather, in Nigeria. So that resistance in quotes, I took good notice of it. And I added unpacking the realities. And it's quite deep as to what the current realities are. And I want you to believe me. And I'll beg for that, but I'll prove that we can understand some of the dynamics that's going on in Africa, of course, here in Nigeria. Next slide. So one of the things we'll do, I have tried to put this discussion in some packages, and then it can help us all conclude together, because I've left the conclusion for all of us to do. I left the conclusion. So we'll follow in so many, of course there are histories we can give around what malaria is, and globally, and of course in Nigeria. And many people have argued really whether we'll be able to take care of this disease, whether we'll be able to kick it off. But I just want to show here, as you see, by 2010, you see this here. You see the entire country in dark red. Malaria was everywhere. It's holo-endemic. You're likely going to treat it then. You're going to encounter it. And that is why it's worse. The highest index of suspicion, fever. All of them, it was the highest index of suspicion. So it will likely be malaria for children less than 5 presenting with fever. And then, of course, in adults as well. But we've seen the changing epidemiology over time. In 2010, in children less than 5 years, we saw that the national prevalence was 42%. And of course, because malaria is heterogeneous with different endemicity in different settings, we saw quite a lot of differential in different times when population studies have been carried. And we see this downward trend from 42% in 2010, 2015, it dropped down to 27%. And by 2018, it had come to 23%. And from the last 2021 population survey, it just dropped by 1%. But why it was dropping like that nationally? There were changes in the dynamics across the states in the country. And from this publication here, so we show that the North has more malaria, the northern states. In fact, they have more malaria prevalence, they have more malaria density. And of course, part of the area that has not changed much is in the Northwest. It still come down to that part. And of course, we have literatures where we already know that even right from the 1940s, in that same Northwest, from Zamfara, Sokoto, all those areas, down to Abeokuta and Ilaro, there were very high prevalence of malaria in the population and in children. At that time, they actually published up to 98%. So you can see at that time, it's easier to take the medicines. You don't need a diagnosis. And of course, that followed through. But the dynamics continue to change. Why Ogun State still remains pretty not as high as the North from the 1946 data. Part of Kebbi states and those, they still remain very high, even with all the interventions going on. So you have different dynamics, and you can see the different colors showing the changes along the parasite rates. So what we know is that the epidemiology of malaria is changing. And for those of us in Lagos, where I have worked and done both clinical and population-based research, we know too the dynamics. You can hardly have malaria confirmed in many of the health facilities, public health facilities. Of course, during the rainy season, you can see them emerging, but it will not give you a 15% test positivity rates in most parts of Lagos. And in the typical mainland, you will not get 10%, even in children. And in areas where you have higher prevalences in the semi- or peri-urban area, like Ikorodu and some other places, you'll still be having far less than 20% of patients being confirmed with parasitemia by microscopy or RDT. But of course, you can have submicroscopic parasitemia that the microscope is not able to deal with. But again, it just tells us at that point, what are we managing? So I just told you where we have come from, how we have the parasites all over, and of course, there were good vector control then, but likely people who are sick of malaria, children with fever, and others will likely have malaria. But that notwithstanding, malaria is a very frightening disease. It still kills, and it does kill a lot. We might be in the urban area and not doing what is going on, but in those rural settings and other areas, people still lose their children for malaria. So the need to be vigilant is very important. Now, I've decided to copy here the national guideline for diagnosis and treatment of malaria. We all know this, right? This is the 2022 document. And I just copied everything here. And from 2009 to 2010, of course, you know, WHO gave the recommendations to malaria endemic countries now to begin to confirm before treatment. Of course, we lost the good medicines, chloroquine, which was very good and very nice, good guy. But the parasite got resistant to it. 2002, they were all indicators of in vivo resistance to Plasmodium falciparum. So this guideline, of course, has been on since 2010. We have the 2012 version, 14, 15, and this current 2022. And by next year, if there are no big changes, it's going to be updated. Now, these are all the medicines we know. But part of the thing is that if you confirm that there's parasites, they are likely going to respond to the known ACTs of the right quality. But if there are no parasites, which you're likely going to see in most of the cases, you'll be treating a disease that the patient doesn't have. And I'm sure a number of us will have this experience. And then people go back to resort to taking chloroquine, which is now even prohibited for the management of malaria. So I've put all of these medicines here, which you know, the various combination therapy. And these are all on the guideline. And I already want us to have it, this guideline, if we don't have it. But it has stated all the known ACTs, even as spies that we have. And the medicines should be efficacious, given their combination nature. And if they are in the right formulation, and the patient has complied with it, you know, of course, if you do the parasite clearance, 24 hours parasite clearance and fever clearance monitoring, you see that close to about 98% of the parasite would have been reduced. And what it does is that the ACTs are the forerunner to cause that drastic reduction, and then the partner medicines, 4,8-aminoquinolones, we take the other one out from the body. So all these combinations are available, and they've been taken. And of course, sorry, next slide. Next slide. Okay, so, and we have this algorithm, all of this put here. Since 2010, not exempting anyone, even those that present with severe malaria, from testing. And the testing, and of course in children, where you would have just done your presumptive treatment with antibiotics and anti-malarials using the ICMI guidelines, that one is even off. You still have to test for everyone. So, of course, the rapid test is there, and it makes it easier for it to be done. So testing is required, but we've seen something here. The healthcare provider's capacity to manage a negative test is a challenge because of all the presumption that that fever or that arthralgia and all will be due to malaria in children or in adults. We all know the signs and symptoms, and the diagnosis is done. But there are issues with that. Sorry. Next slide, please. Oh, I should be turning it, really. I'm in control. Oh, my God. So what it does here, what it does is that I just showed what I said. You can see what ACT, that medicine does. It brings down the parasite body mass quickly. And you can get that in the first 24 hours. And then the other partner medicines, lumefantrine and modafinil, they go to mop it up. So they really have to work. And when the resistance is coming, in those days, of course, we've seen that the 4,8-aminoquinolones, of course, had a long history, resistance, especially for chloroquine in the late 50s. And I bring this here, this data. Every 2 years, the malaria program does the therapeutic efficacy studies, TES studies. The TES studies is what gives the country an indication of how the anti-malarials are functioning. And they do it regularly. I think there are some planned now. And they do it in selected sites across the country, maybe 7 sites, in case they are different. You know, the parasites have some populations, but I'm going to talk about resistance now. And so what we've seen across all the medicines, dihydroartemisinin, piperaquine, AAA, and all of them, you see all of them from the 2021 data, they are all above 98%. And that gives us, because if it's below 90, then the medicines are resistant. But these are done following a very strict protocol. And that's the TES protocol. If we don't follow that protocol, we cannot talk about resistance, unfortunately. So when we go to the facility and we speak with the clinical managers and they query resistance, I wonder how they got it. How did they get resistance? Of course, we'll look at the drivers of resistance. But you can't query resistance when you have not looked at this protocol. The protocol is a rigorous clinical trial protocol, and that gives us fidelity. So this one, at least first of all, we assure us, if you have the right quality, and you have quality in all ramifications, yeah. You ensure bioavailability of the medicine, yes, it works. The parasite are sensitive to the anti-malaria medicine, but there are challenges. So, we talked about the new emerging era of resistance. Are we talking about that? So we have some good confidence. I do have confidence. And the reasons for all of this, we know, because if the patient has malaria and takes the ACT, there will be in close to 99% a good clinical outcome. So it's been seen in children. And the guideline talked about treatment failure and just told us what to look at. Of course, from observation, there are things you can tell. But we must see that all the parameters are all operational. The quality of diagnosis must be speaking. Because if the quality is not okay, you're likely going to keep on having a positive malaria parasite results, MP results, continue to have positive. And that's what we see likely most times in facilities. So, but it has been brought up here. And of course, the issue of monotherapies that are not allowed. Because if you look at that graph I showed you, one quick medicines must go in. And the partner medicines will have to now really begin to work. And that one will now do the utmost clearance. Because if it's not cleared, if that parasite population is not cleared, you are not likely going to have a build-up of another new parasite, same, but that has changed. One of the things I want to mention here, the one I showed that the illustration of the parasite, is that the parasite alone is a mutation master. And it can change for any reason. Even if you allow sleeping dog lice, it will change. Then if you now disturb it with your behavior and other attitude, then it changes faster. And you now have different subpopulations of the parasites, which of course, in another cycle of infection, you might have that poor response. So monotherapies are not recommended. Any of the artemisinin or derivative as monotherapy, not ever recommended. Of course, except for severe malaria where IV artesunate you will have to use, and the reason is to really take care of the body mass of the parasite immediately and restore some stability in the patient. And these are all the classification. So when you follow that protocol, this is WHO, of course, we have it in our own guideline. You can see what you're supposed to be getting. This is the end point of where we should be coming to all the time. You want to see adequate, at the bottom, adequate clinical parasitological response. In the time of chloroquine, there were other definitions of resistance. You had R1, R2, R3 resistance and co. But these ones, and you can actually have the early onset where you have asexual parasites still in the body at day 3 when ordinarily they should have been cleared. And of course, day 7 you can have that. Day 14, there are different protocols. Depends on the medicines that you are that you are evaluating. So you can have up to the 42 days protocol and a 56 days protocol. So it just tells us how to evaluate those results, and you see with failure from WHO guideline. So this is the parasites. So that this parasite, as you say it, is a master and is strong in the game. I remember when I was giving my inaugurals so many years ago, I was arguing whether these organisms are more intelligent than humans. And the argument, too, with some hypotheses was, are we the one allowing them to drive the game, or they're actually smart? So yes, they could have some capabilities to weaponize our system. They could have unique ways by engaging the erythrocytes and sticking to humans and dodging to deeper organs and all thus mesmerizing the entire system. But humans, on our own, we argue that we know what to do. If you don't open the door, you will not have a thief coming in. Or the thief may want to break in, but you can reinforce it. So that is it. And their capability, Falciparum has great capability. We all know that. So, resistance. And the practitioners will have to know this before we settle for it. We need to know how we arrive at that. Yes, you can query it, suspect it, but what do you do? So will you pronounce resistance? Of course, the likelihoods most times is that you may not be just treating this disease. We are addressing those ones in the facility now, what they should do, and how patients presenting with fever should be properly managed. But everybody seems to have just gone into one old school like that. That is difficult to pull them out of the boat. So, but there are a couple of things here, and I've underlined this. Not all treatment failures are due to resistance. However, resistance results in treatment failure when the parasite is resistant. And there are triggers around that. Although in the country we've not been able to do all these full-fledged pharmacokinetics, in vitro efficacy studies in the therapeutic efficacy studies we do. Because you need to look at whether the medicine was actually available in the patient before you begin. But we do the molecular markers along with that. So the drivers, I don't know whether you can see that here. But in three categories, you have the parasite factors, the host and drug-related factors, you have the environmental factors. From the parasite factors, yes, we want to assume that it's a parasite. There was an infection. Now, let's look at Lagos State and the urban area. WHO is concerned, and we are all concerned about urban malaria currently. We're not in the village, but it's urban malaria. And the malaria will stick around the building because they are unkept materials that can still cause breeding. But when we see all of those, no matter what we describe as urban malaria, we must raise a big flag on the entire fever management. And that's why part of this study we'll talk about malaria, but we need to go look at the evidence around where other etiologies that causes fever abounds and causing disease in children and in adults. So like the parasite can do quite a lot. And that's the number one factor. When chloroquine was showing resistance to Plasmodium falciparum, there were some new genes that were supposed to help keep the medicine in the parasite vacuole. But that gene, one of the resistant genes, the PFCROT genes, when it changed, it now resulted in the efflux mechanism, which we know. And rather than the chloroquine staying in the vacuole to kill the parasite, it pumps them out. So he becomes a smart guy. So he pumps it out. Of course, there were other medicines that could still retain they ensure that the pumping action is reduced. But it's lingered. And because I know and I hypothesize that maybe things have started changing, that the pressure had become so much. Of course, we know that the chloroquine resistance started from Southeast Asia. That's where all the resistance started from. And of course, the parasite, what it does is that the drug must be in a vacuole, where it can cause death. But the parasite, again, is still smart to transform, because you have the hemoglobin, which, of course, will have to be broken. And when the hemoglobin is broken, the hem that is released itself, and that's how all the targets of anti-malaria medicines were all discovered, that the hem itself would have just destroyed the parasites, and we all will have peace. But the parasite polymerizes that hem to hemozoin, and now become a safe material for them to thrive on and to be in our bodies. And they continue to do that. So what most of the anti-malaria medicines do is to go and recouple and decouple the hemozoin and open the hem so the parasites can be killed. Now, the host factors, of course, you can see changes to malaria in pregnancy, where some immunities are all dropping. And you see that, again, the parasite is able to, apart from that differential capacity, is able to still stay around, because we have premonition that still helps us maintain IgG subclass 2-4 to still keep us healthy with temporary immunity, especially in adults. But all of these ones are all broken during pregnancy in pregnant women. So the parasite, apart from the fact that they will all go to sequester in the placenta among the other deeper tissues they still have issues. Then, of course, from the environment, it has to do with the transmission and how other factors from the vector is now triggering changes in the parasite itself. So when there's a new vector now, Anopheles stephansi, for instance, it's a stubborn mosquito vector. Even before Anopheles stephansi, within the parasite, there are changes that are triggered in the genetic makeup of the parasite. So the parasite, some of them will lose some of their targeted gene and they'll be deleted. And when they're deleted, it creates a lot of opportunities now based on that environmental condition in the vector, outside man, for them to fester in man. So that's how it happens. And of course, several genes. Then, of course, you have treatment-related drivers when the medicines are not taking the right, when there's no compliance. Of course, too, when you have substandard medicines, when you expose the entire system to anti-malaria medicines, they all will all drive. And they all come in different ways. Proportion of parasite exposed to drugs, incomplete treatment, parasite exposed to drug, which they are not fully sensitive. So with all of this, this malaria falciparum just keeps on changing and return to something else. Falciparum, when it gets to a peripheral circulation, will come as just one clone. Within, when maybe symptoms are coming, they are all changing to different variants. They have different population. They call that diversity in their population. So these things will happen. And a number of all of these genes, both for chloroquine, 8-aminoquinolones, all of these ones, they are resistant, and there are those that are still sensitive, but they've all been really genotyped, and we know that apart from the in vivo results we have in Nigeria, and then the genetic analysis, we've seen that the genotypes that carry resistance exist for those 8-aminoquinolones. So that's why the pressure around these medicines has to be guided. We have a role to play around that. Then, of course, for sphatoxin pyrimethamine, so we know the resistant markers, and these are the haplotypes, the various genes that are controlling that. Two major genes in the sphatoxin pyrimethamine. Okay, so PFDHRO and PFDHPS. And all of these have been characterized. We have results in Nigeria that shows this. And that's why adults cannot take sphatoxin pyrimethamine. For women, yes, we've still shown in that adult population, yes, for some reasons, the parasites are still sensitive, and when given as dots for the management of malaria in pregnancy, we still see good outcomes. Okay. Okay. Now, while that one was going on, the artemisinin, so while that one was going on, the artemisinin now developed resistance. They call that the CATCH13 gene. So the CATCH13 genes have all of these genotypes that can cause resistance, C5HOY, and all of those numbers you have read. Now, we have done studies here in Lagos, and we publish other genotypes for artemisinin, but it does not have this resistant genotype. And Nigeria is still clean of this. If it has any suspicion, of course, WHO will tell you, if you have those resistant genes more than 5%, you begin to feel unhappy. So for us here, we don't have much of that. But we've seen in Africa, and WHO had to really come out because they started seeing these genes in Africa, how it is emerging. So seen in Rwanda, in Ethiopia, Uganda, but in some cases, especially in Eritrea, and then in Rwanda, 15.3%. So it's pretty high. So it meant that they really have to now begin to come up, see how they can contain the spread. But many factors will still be driving that, especially from the environment and the vectors, which are changing. In Ethiopia, we are seeing new vector species spreading, and they are helping, because if the vector can always get to you, that's the fancy gets to you, they will trigger other genetic changes like deletions in some of the genes of the parasite, and those parasites will fester, and they may not respond to your medicines. So we see it as emerging. But Nigeria, from the genetic point of view, for artemisinin, we are still okay. So part of what is the challenge is how we're able to ensure quality of medicines, quality of formulations, and how the post-market surveillance can deal with those, especially a number of them should be table stable. But again, we have a major challenge, which is the place I will still be going on. So, to look at the case management goal, why are we in case management? What do we seek to achieve? One is an overall public health goal, which we all sign up to. We sign up to that public health goal, apart from the fact that you are trying to get someone who is ill and to make that person well. The public health goal are here. Number one, if you detect early and you confirm, and you have the right medications, quality assured medications, the patient should do well. But you will definitely slow down the progression to severe malaria. Now, there was a severe malaria study that was done recently, and we are seeing a transition from children to in ensuring access to quality medicines and the diagnosis. The community pharmacies will have to be more responsive in this. But there are some gains I will talk about, because at the end, if we say you are likely going to negate malaria, but other cause of, and there are little test strips that you can use to, when you negate those, you want to manage the fever properly. And then that is still sizable, because we must look at the outcome in the patient and how satisfied they are with our interventions. So all of these are very important. Of course, if you treat rightly, so you will still delay the onset of resistance. So we'll set that overall public health goals. And this lecture too is still part of that. It connects to how we were able to deliver on that public health goal in what we do. In fact, of course, you use vector control, you use that, but when it comes to case management is one of the transmission reduction strategy. By the time a patient is in the home or in a compound, one of those that have malaria, they get tested and treated early, then you break transmission in that household. You break transmission in that environment. And then, of course, the recommendation still has to do with quality testing and then far more reduction in clinical diagnosis. Because what is fever or I feel unwell does not mean anything in the realm of science. And we must deconstruct that. We must now go to look at. They are all expensive studies to do, but we really do have data around how all of these things are panning out. Sorry. So this is WHO's recommendation that wherever we are either dispensing and where we are selling medicines, diagnosis has to be done. And the RDTs are very good. I'm sure some of us have a lot of questions whether RDTs are good. Yeah, they are good. They are good if you get the right ones. They are good. And then we have this policy, please ignore that. You have the WHO's test, treat, and track. And then we know the clinical features. But basically, for malaria, we just need to classify it quickly, the uncomplicated one. And when we say uncomplicated, it's not an easy thing because you cannot have acute uncomplicated malaria requiring hospitalization. It's the same. You don't have organ dysfunction or anything, but it's the same uncomplicated, but it's not acute. You're not able to eat again. You're not able to do anything. So the medicines will have to be available when the test is done to deal with that. So these are all the things we know already. I just put that there. So I begged you to believe me when I came, when I was making some statement, introductory remarks, that we were going to say it. These are all the stuff for diagnosis, for routine diagnosis, we all know. And we keep the RDTs in our pharmacy, and they're there, and they're useful. And so we've seen again that even with all of this happening, we're not seeing significant tests being done. So there are many reasons you could query the medicine if you're not doing the tests. Have positive tests. The medicine should work. If the test is positive, microscopy will likely give you what was not there in most of the cases, unfortunately. So you ask, so what do I do? Use RDTs until we get the other people, we'll get them to work up. But you can see too that even in the country where some of us are players, and that's very good because a number of us are from the public sector, maybe. The public sector is not tapped at all. And that's where most people present. You know, from the data we've seen consistently in all the population studies, looking at guardians and parents, you know, we've seen consistently that over 60% of those who seek treatment for malaria, they go to private sector. So, but the tests are not being done. But from public facility reports, we see that they are doing the tests. But the reporting, again, is problematic, so for Nigeria. So that's how it is. So there are many reasons. Did I disturb you? Or you want to solve the problem of Nigeria now? Okay. So there are many reasons why we have to do a test. If you don't do that test properly, you will query the medicines. But apart from querying the medicines, you will be affecting the patients because they will now keep on taking medicines that they don't need. So, and the caveats, when the parasite is there and the quality of medicine is good, ACT, it works. If they are all available in the formulation recommended by WHO and from the country, they work. If they are stored properly, because you have to store them properly as well. So all of this, the danger is you have other conditions that can cause pyrexia, that can make you unwell. That first introductory slide I showed you, when everywhere was dark red, you'll be making a positive prediction. You'll make a confident diagnosis. In fact, I would dare call it accurate when you give somebody chloroquine. But right now, the condition has changed. We can't get a confident result with that anymore. But it's quite positive. There's pneumonia, there are comorbidities. We must begin to look at that. I will tell, when we go to the facilities, we tell practitioners, nobody comes with a disease in his forehead. You cannot be a monothinker. You cannot. Just look at, and of course, I won't want to mention some descriptive, some words we have used. But we almost really take some time to, because I see data from the 36 countries. I see the behavior. We monitor the test positivity rate. We monitor medicines use. That you still see 30% use of ACTs and we go to facilities and they have very low test positivity rates. And we are getting the pharmacists, what are we going to do about this? We have some activities we'll be rolling out now in most of the global fund states. We want the director of pharmaceutical service to be there. Because best practices and professionalism, you can't trade it off. That's your life now anyway. And we must stand for it. So the director of pharmaceutical service will see how the medicine consumption is and how it's tallying with what they are treating or not treating. So good clinical practice is very important. Description of fever is quite large. It's a big box. And I'm showing here from studies that have been done here, we have reported quite a lot of reports that are changing the narratives. There are reports of overdiagnosis and overtreatments. And we've reported even for places like Lagos, where you have pregnant women, they say everybody, it's not true. It's not true in most cases. So those data, and then here we looked at adults 20 years and above that visited the medicine retailer shop, and we did exit testing for them in 5 states in Nigeria. And we saw that of all of these, only about less than 10%, about 8.9% had parasites that were confirmed among those that bought ACTs. And that was actually misuse of medicines. Now, the patient may not come back to you. You go elsewhere, so you won't be able to track them, whether they were happy with the outcome or not. And so we have all of this. There's a profound study here talking about beyond malaria. And that's the point we're looking at, even if you're looking at comorbidity, both from the point of infectious diseases, communicable diseases, and from non-communicable diseases. They will present the same way. All you need to do is to see how they are negated. So looking beyond malaria in that patient and looking at all this medicine, it does bring a lot of caution as to what we can do. From that study, very deep study, we've not been able to try to do that because it's so expensive to do. Look at all of these etiologies through PCR. But you can see that in Tanzanian children, look at what this where malaria is. One of the first top cause of this disease is upper respiratory infection. So you see influenza, you see herpes viruses, and see all of this, and you see down malaria is the 1, 2, 3, 4. And of course, you can see others that can cause diseases, urinary tract infection. They all present the same way in those patients. And then, so of course, in Lagos now, there's acute febrile monitoring going on. These things are real, and if you keep on giving these people anti-malaria, they're not going to feel well. So, and it's gone beyond just seeing how these children look like this. In that historical account I told you, you are likely to say, yes, they have malaria. But these guys, here, they could have any bacterial disease. They could have anything challenging them. And you cannot be too sure until the test is done. Meningitis. So I'll leave this slide for you. It speaks quite a lot what the health worker does when a test is negative. Because it's our mindset thing. They still go ahead to treat. The red lines are all the unacceptable actions taken by the healthcare provider. And this is a teaching slide. And we'll try to see how we shift, healthcare providers to the black line and what they should do. It doesn't matter. Patients, of course, self-diagnose themselves when they come to the facility that I have malaria, so I need to have that. So how do we handle that? So we've seen too in Senegal, in our society, because we're an infectious states. You have, infectious disease states. When ACTs were given, let me use this. When ACTs were given, they were used large scale. We see a reduction, but this red line, fever still remains constantly high. So these are areas we just need to unblock. And in the facilities now, they are doing well, doing the full blood count and differentials with small equipments, and they're getting better. And then we see, again, this is the graphical presentation of what I just showed in that febrile disease matrix. And you begin to see the contribution of other specific etiologies to fever. All of these ones will not respond to your ACTs, if that is what it is. So the same thing too in terms of disease, just showing the proportion. So you can see where malaria is now. At that time in Tanzania, 25%. You see the upper right quadrants, and you can see other diseases. So I'm running off, and then, so most common diagnoses according to a group, you can see the urinary tract infection and others that have been recorded there. So I have spoken from one point of epidemiology, where Nigeria was several decades ago, and I will allow us to be concluded. And I spoke about the reduction in national prevalence or incidence of malaria. So how do we conclude? I talk about resistance. Yes, resistance is real, but the resistance to artemisinin is not seen here yet. The resistance that we saw in 4-aminoquinolones with chloroquine and all of those, we saw it and we nipped it up, and we have the ACT combination treatment, therapy, and we are seeing that, yes, the ACT will still give you close to 98% reduction within 24 hours, fever clearance, parasite reduction, and then the partner medicines are able to take that out, the remaining out. So we showed that. And we showed too that if you're not testing, you're likely going to be treating the disease that's not available, and you will query resistance. I also said that there's a protocol that we need to follow. The federal government does that every 2 years in different locations, and we're able to have the fidelity that these parasites, these medicines are efficacious, and we can use them. But there's a caution. The caution is about the quality of medicines, the kind of formulation that is used. In the area of fake and counterfeiting, those ones were challenging times because nothing will happen. The parasite will be happy when they take those kind of medicines. And so I've said all of these, and I've talked about the non-malarial febrile illness, NMFs. We need to understand that comorbidities and other causes of disease. In fact, the guideline, you have to follow to rule out and to be able to assess for other causes of fever. It's the responsibility of the healthcare provider to do that. The medicine we have right now is not a blockbuster medicine, unfortunately. Short half-life for artemisinin and the derivative. And the other ones, do they have anything? My friend at the London school called me when I went there, and he was showing me some remarkable things happening within certain travelers, Nigerians. That, of course, when we go there and we fall ill, the bloods are properly kept, and they do a lot of testing on them. And it shows that some resistance could be emerging from the partner medicines, not artemisinin, from the partner medicines. But it's just one observation. But to give you the fidelity that the federal government did do the test. But I'm sure too, like I always say, that testing results is not still properly communicated to a number of us. We don't know what they're doing. So how this can be done, the executive, there are stuff that should be available in our phones. When those results are released, they put in packages so that we know, no matter where you are, you now know that within your location, because they will disaggregate them in study sites. I know Lagos site used to be a place where they enrolled children. But sometimes if you bring that study to Lagos now, the study can take you up to 1 year. You're still looking for students that patients that meet the criteria for enrollments. And we've seen that across, just empirically, in many places where they do those trials. It's difficult to enroll those children. And normally the entry paracetamol should be close to about 10,000, reduced to 5,000, reduced to 2,000, and you're still struggling to get those children enrolled in the study. But in the north, you can enroll those children within some few weeks. So now, should I leave the conclusion for you, or are you going to ask me in terms of questions? So while we are interacting, we'll be answering. Okay, you want to do that, please. Thank you. Go ahead.
Okay, let me.
Okay. This one is anointed anyway, but let me hold it. Let me. You can come too and take some.
Okay, thank you very much, Professor, for the elaborate and lucid presentation. So we all realize that malaria resistance is an emerging issue, is a public health concern for us in Nigeria.
In Africa.
In Africa,
not
okay,
in Nigeria,
and in Nigeria in
the
particular.
Testimony I gave.
Okay. Okay, so my question has to do with the issue of RDTs, okay, because from your presentation, it's obvious that the resistance issue is multidimensional. It has to do with the product quality itself. It has to do with the diagnostic protocols and all of that. So for availability of RDC, so do we have any federal government program that could make RDTs available in maybe community pharmacies or even in hospitals? For example, in my hospital last suit, several years ago, we used to have RDTs provided for physicians to use in their consultation rooms, but that has stopped. So I think that is a major intervention that could be done. So is there any federal government program regarding that? And then another thing I also want to comment on has to do with establishing the quality of the products that we make use of. Apart from what we expect regulatory to have done before the products are released into the market, I think there's also a need for surveillance of the actual products that are actually stored, because sometimes you find gaps in between what regulatory has approved and what is actually circulating. And I'm also looking at a way that pharmacies can also do some kind of quality control. Okay, I know that there is a quality control lab in Lagos State, for example. So all of those things, I think they're going to go a long way in helping us to combat malaria resistance. Thank you.
Thank you. Thank you. So again, I will congratulate all of us. The reason is understanding where we stand in the in the pipeline. We're not ordinary. We're not just maybe trying to do a business. We're not just trying to do some work. I say it as because if you can imagine, if there's no professionalism, people who can say, let's do this in this way. We had the quality control testing lab at Luth. But some of these things are no more for medicines. And sometimes when I work, because I work in public institution, and unfortunately, when you look at those who occupied our offices before, they were more diligent. I want to ask you. And we all cannot be looking out. We need to really come down to say, and we're in a changing world. Part of the hypothesis on anything we do is that things are likely going to go wrong. Just take that first, that things might likely go wrong. Then you begin to be proactive. Now you increase your vigilance. And you say, this is what we're going to do. There will be profit in that good thing, of course. But it has to be right. And I have grown into a position of leadership. And I took my leadership. It wasn't given to me by who I am. I sensed it. That can I effect changes in my environment? And it must start with me. I do it. So choose to be different. But let's talk about the professional agenda. One, some things may not be available for you for the asking anymore. Because before there are places, the budgets are always very clear. But sometimes the budgets are not there again. So we have to study and learn diplomacy to succeed in our work. you cannot have it the way it used to be. So how do you get the thing? So you have to get your data, try to know what is going on, and where the shift has to occur in a facility. And then you can see, sometimes the healthcare professionals refuse to be economists, but we like money. But why not do the economics and present that data? For instance, and there are fatality issues, how our brothers, our relatives can be affected, our friends and others, human beings, not animals, can be affected. We need to get the data on how these medicines are working. What do we have the power to establish or to catalyze? I have some opportunities myself, and I said, I'm going to do something that is different. So we have to identify. The primary thing for every healthcare provider is observation. Let nothing try to just derail us from that. We must be good observers. So, for the RDTs, Lagos State was not having, I think now there's a new funding regimen for them. And lawsuits, I'm sure by the time it's done, you can begin to have. But we've seen in facilities in Lagos, they buy. Randall, the drug revolving, it works, and they buy. And surprisingly, and that's where we have to hold all of us responsible, because they're telling us that test positivity rates in some major facilities is 2.3% a month. We are General Hospital adults in Lagos Island. By the time we got there in April, they've only seen 8 malaria cases by RDTs, not by microscopy. So where are the medicines there? So, but we can't query, but if the patient doesn't have, now this is what happens. Because you have the partner medicines, acetaminophenolones, they will still help the patient for a while with all the anti-inflammatory effects, antipyrexia, and all of those. Patient can still feel a little well, but we'll come back again. So that's partner medicine still does some things. So, but you'll get soon. But see how the drug revolving, because if it's going to be free, it's going to be we need to really knock our heads together. How we're able to have access to these quality medicines or diagnostics. We host the WHO Lot Verification Center for RDTs. And yes, there are some RDTs which are not too strong to be in the market. And that's why in all of this, there's a point of contact you can always have to see that the right stuff is. But it's our duty to have all of these things down. And of course, the management. I know so many things have collapsed. Clinical pathological conferences that holds with everybody. Usually is a blockbuster thing for everybody to say, we all own these patients in your clinical pathological conference. That is done. With everybody being there, and then you are proving your case. But the clinical meetings still go on. So it's for us to go there and get things done and get things changed. So, and for all of this, in our own different teams, we cannot solve it alone. Everybody must come together to just hit it out.
Thank you, sir. I just want to give us an information in response to the last question asked. Some 10 years ago, more than 10 years ago, the WHO actually said Africans, especially Nigerians, we waste a lot of money on malaria treatment that is not there. So they actually gave test kits through, we got the test kits through the Lagos State government. I was in Masterclass Children's Hospital, where they treat children for free for everything about health. So they gave us money that wasn't sufficient for buying the medicine themselves. So we always had that problem. So we pointed out from pharmacy that, look, we're wasting money on anti-malarials when we needed cephaloxyms of this world when patients have... So the MD bought it. He now gave the order to doctors that pharmacy will not dispense if the RDT is not included on their prescription. So initially, they agreed, then later they said it doesn't work, and they know that the patient has malaria and this doesn't work. The MD came in again and said, if it says negative, that's when you send to the lab. The lab is the final judgment. And most of the time,
The lab says they are positive. They are negative, meaning that the RDTs most of the time worked. So now they still continue to resist. So he said he was going to sanction any doctor that prescribed and without a proof that they should actually give us the disc to see that, yes, this is positive. Then we'll dispense. And the result was that the rate of use of anti-malaria was less than 50% after those. I wish we had the access to records today to go and check that and write a beautiful research work on that. So it actually works most of the time, but there is that bias that it won't work. But let the lab be the final judgment. I heard that in Lassos, they said they should give the kits to the lab. The lab doesn't need that. They have the way of identifying. That's the final decision. The test kits should be with the doctors before prescribing. It doesn't take time. Just prick and see it and wait. It's less than a minute thing. The thing will show. And then you can now write, okay, this is not. Then you focus on something else and not always on anti-malaria. Thank you.
So thank you very much. I like that, focusing on something else. We have, of course, science will tell you as you begin to grow older, that population still exists. And the children population. And
I hope we can take the questions together so that I won't waste time.
Okay, just 1 second, sir. And just taking that leadership, what they got, yes, lab can be the final say, but it could be problematic too. They have to be ready to play that role. Because what you see in most facilities now, the results for microscopy may not be available until next day. And people will treat. Please go ahead, sir.
Yeah, thank you, sir. Very educative and lecture. I really enjoyed it. In the course of delivering the updates, the Masterclass, you made allusion to the distribution of malaria in the country. And you did mention about the Northwest, where it is endemic. And of course, from Northwest, Kebbi, wherever you move it down towards Ogun State.
Yes.
Now, my interest is in Ogun State.
I know now.
Because Ogun State and Lagos, when we have second Lagos, when we say second Lagos is almost Ogun State. And it's very close to Lagos State. So, what is the situation of things with respect to the density, malaria density, in Ogun State, vis-a-vis Lagos State, as we have now? And in the course of the display of the resort for the National Population Resort for the malaria, for 2021, it was 99% all true. But the value for 2020 caught my attention. 2020, where you have, for AL, you have 81.2%. For AA, you have 91.2%. And for the PA, you have 85.2%. You can see that 2020 was very close to 2021. So what necessitated that result for 2020, where you are not having anything up to 90%? What are the factors responsible? Is it due to fake drug? Or what really happened? So that's my question.
Okay. Thank you. Hold them.
All right. Thanks for the presentation. So 2 weeks ago, a mother was sending 3 children on holiday to my place. On the day of arrival, I waited, and I was told the boy, 6 years, got ill, and I said, quickly take him to Federal Medical Center in Abeokuta. They went. They ran a test. I said they should run an anti-malaria test because 2 weeks before the time, the boy was treated. I was like, what's the cause? So after the test, I said, tell them, I said they should also do parasitological test. That one, you pick it tomorrow and you come back. But the 2 tests proved negative. I said, bring him down. Let me monitor by myself. The boy came, was still very, very feverish. The body was so hot for another 2 days. I didn't know what to do again. I said, but after the first treatment, did you give amoxicillin? He said, yes. I said, okay. I now consulted one of the consultants in my office, and I said, this is the challenge I have. He said, my boy had the same thing. You are going to repeat the artemisinin therapy, yes. And then this time you are going to add antibiotics. I said, which one should I go for? He said, if you can afford Rosephine. I said, I can. Now, we gave a parenteral injection, first dose of the artemeter, then followed by we completed orally, and then he also took that Rosephine. In fact, in less than 24 hours, he was good. And since then, he has not been sick. He has not been having that issue. Now, I want to know exactly what actually went wrong. Which one? Was it parasite? Was it malaria problem or something else? Thank you.
Okay, thank you. All right. Okay, 5 minutes. Okay, let me start from the last one. Now, when all these things are going on, in the case of fever, we never had the full blood count test done at all. How many etiologies are you going to look for? You have about over 300, 400 etiologies. So will you test for malaria, test for strep pneumo? How many will you be testing for? So we must look at comorbidities as it happens. You do, of course, the easier one, you do your RDT, and then you do your full blood count and differential. Let's allow the children live, because we begin to hop from one place without doing those tests. You can tell. And then there has to be a clinical exam. So you want to see, it's not about, what we say is that the time where you just touch and write prescription has gone. It has gone. It has really gone. You just need to do the exam. You open the mouth, you check the ear for children, see properly. And then we order a test. And the system must be made to work. If not, we should not weep when we should be laughing. But at the end, something comes close to you because of a failure around us. We must be responsive in the different units. The laboratory must be responsive. They must do all it takes to be responsive. Now, those of us who work in public sector, we do all the fights. But there's no fight in public sector amongst anybody. You follow the rules. Check out the private hospitals. Check out they all do 100%. We all they work together. Public sector, we bring all our African thing into that place and nothing is working. So the other one, that DT results, you can see though it was 2018, there were prolonged issues. The drugs they use for all of these studies are brought from the manufacturers. So it's not a question of quality of medicines at all. But again, as a country, a clinical study must be up to its weight. So, and these are pooled data. But if you look at some of the sites, they actually showed some very clear 98%, 90-something, but it's pooled across to give us a national figure. So one site's issue would have dropped them significantly. Then for Ogun State, which I'm still also very interested, because here in Lagos, those of us who are from Lagos and Ogun State, we are trying to push things. Ogun State borders Lagos. The other part is the Atlantic Ocean. And what we hypothesize and what we see is that you have higher transmission of malaria in Ogun State. So, long ago, the former commissioner had to call Dr. Shoyinka, and we all met together to see how we can do it. So we need to foster that brotherliness again. Because we know the heat spots in Ogun State, all around bordering, Akute, Shagamu is high. Ijebo, and we were working, actually reaching the Commissioner of Health for Ogun State, that we need to have a good handshake. Some of the things we're doing here, we want to do it there. And then we'll be in Ogun State next week. So, and we'll talk about that. No problem, you are safe.
Can we do more for Prof?
Thank you very much. I will wait my conclusion by email. Conclusion will get to me through Greenlife Pharma.
Thank you very much.
Thank you.
I did tell us that Before we started, we said malaria is gone. Do you still have malaria now? Thank you, sir. Very important information, please. There will be tests after this lecture. Yes. 4 questions will be put up there on the website. I'm serious. You know, my case is like, because I'm not a serious person, you think I'm not serious. One other information you should take again is that there's another test you must run when you have any febrile condition, and it's called cytology. Please take note of that. If you check for it and you find it is available, call me. I am the only one that has the solution. All right, so we'll be running up Greenlife session with presentation. Prof has told us all the other parameters. We want to finally chase away malaria from... They said malaria is in Ogudu State. Did they say so? Did they say so? My area of Ogudu State is inside. It's not at the border. Let's welcome Pharmacist Okolo Henry, the product and marketing manager for Greenlife, as he takes us through his session for 15 minutes. Thank you very much.
Yes. Good afternoon. Okay. Good morning, distinguished pharmacists, fellows, and merit award winners. And permit me to continue to stand on the already laid down protocol by our MC. My name is Pharmacist Henry Okolo, that I've been rightly introduced. And it's not very easy having to talk after an authority has spoken. But after engaging with Prof in the past years, he has always been supportive. And so when we come to a PSN program like this as Greenlife, understanding that we are not standing tall just by the gene of height, it's because we are standing on the shoulders of very reputable pharmacists that are giants. And so when we engage you, we also try to add value to what we are doing because we are a critical stakeholder in this conversation. I've been given 15 minutes, so I'll do my best to talk about Lonart, the effective anti-malaria. And so it's very easy for us to look at it and say, what is there to talk about in Lonart? And so for 19 years, we've been talking about Lonart. What can be new? I remember when I was just entering pharmacy school, the very first lecture we received at the orientation, Professor Katie Jayoba then said, you guys are very lucky that you are entering into the pharmacy profession when there is a paradigm shift. That was the first time I was hearing the word paradigm. So I wrote it down as a village boy that will check this one out. Okay? Now there's a paradigm shift in the profession of pharmacy, moving from drug orientation pharmacy and patient care orientation pharmacy. And it's talked to me because in the course of my journey in the pharmacy world, I've come to understand that it's very, very important. Coincidentally, when I was finishing pharmacy school, after the parasitologist has touched it, a very, very renowned professor also made a comment at a mortality review. He said that medicine is not for profits. That medicine is for the patients. And as an Igbo boy, I don't understand that. But it didn't end there. He said medicine is not for profit. That it is for the patients. That when we pursue patient care, the profits would certainly come. And I agree with him totally. That when we pursue patient care, the profits will definitely follow. We as pharmacists, we are very, very interesting people. Okay, very interesting in a very good sense of it, because a pharmacist sits in a counseling room, in your pharmacist office, and a patient walks in, and in one split second, or 1 minute, give or take, you do a lot of pharmacokinetics, pharmacodynamics, drug-drug interaction, drug-food interaction, pharmacoeconomics, and all of that. and you must arrive at something that would help the patient. And so we see that in that space, a lot of things can be missing. Prof has spoken too much about epidemiology, but I'll just make some salient points here, okay? That half of the world's population have this burden of the risk of malaria, and young children and pregnant women are actually most predominantly affected by this. And so just last year, 249 million cases of malaria were reported, and 0.6 million, about 693,000 people died of malaria. People really shouldn't be dying because of malaria. And so if you come to Nigeria, you have 26.8% of the global burden coming from Nigeria, and 31.1% of these cases of deaths coming from Nigeria. And so Nigeria is actually playing a very, very big role on how this happens. And so we have talked about resistance today, even though we have put resistance in quotes. But the information out there, Center for Disease Control in the United States of America is positing, and they are saying this, that resistance is emerging in Africa. And they try to lay some emphasis on what could be the possible cause of resistance in Nigeria, in Africa. And they have identified that two of the species, Plasmodium falciparum and Plasmodium vivax, are the major culprit of this trending resistance in Africa. And so you can see even in that same space, drug discovery is already looking at what can we bring when malaria resistance eventually sits very well in Africa. And so even in Nigeria, there are publications telling us that there are pockets of resistance. Although Prof has given us a wholesome study of how to understand resistance in the sense of it, that most often than not, you find treatment failure or misdiagnosis being the major culprit of this. But what's our interest here as Greenlife Pharmaceuticals? Because you may be confused that, am I now a public health advocate or am I a salesman for Greenlife? But I'll do a mixture of both, because I took an oath as a pharmacist that I will use my knowledge to protect the community in which I serve. And so in the last 5 years, a lot of things have changed. Okay? And so we are paying attention, and we must continue to pay attention. Because, yes, it is emerging. East Africa, Uganda, Eritrea, very soon. So we did a sentiment study, sentiment analysis of all of this. And what we find out is that some key words are recurrent. And you're seeing words like resistance. You're seeing words like instability. You're seeing words like untreatable. The vector is doing its own. The parasite is doing its own. Prof told us that the parasite is a mutant, is mutant by nature. It's a mutant master. And the environment where we work in our different fields in the pharmacy profession, we have our roles to play. And that is why we come here and begin to shed more light on these things, that we must begin to pay very close attention to them. And so we looked at this study because most often than not, you hear that all antimalarials are the same, all ALs are the same. This study was carried out by a very renowned professor, Professor Kamafi Augustine in Uniben and Awufi Sayo in Uyo. Okay? And we looked at this study. In this study, they tried to compare the bioavailability and by extension the bioequivalence of anti-malarials in Nigeria. Okay? And so they picked 6 anti-malaria, 6 artemether-lumefantrine in Nigeria. Okay? And so they did a bioavailability study of these tablets. AL1, AL2, and how they labeled it up until AL6. And in conclusion, they said only 2 of these 6 anti-malaria meets the bioavailability specification. And only these 2 are actually bioequivalent. So the other 4 failed the specification test. And that is alarming. And they went further to conclude of what are the possible reasons for us having poor bioavailability with the drugs you have in the market. And so he mentioned different poor storage, instability, counterfeiting, okay? And so this is just to drive some of the points home, because as you can see here, this is a picture of our port. This is a picture of the open market. This is a picture of how we distribute drugs by extension, even in our country. And the problem of light. If you look at this slide closely, you'll see that we are living in a relatively humid environment. And so some drugs are not stable to this condition. And by 17th of August, this one struck me. Okay, so I put it out there. And I quote the same quote of the author, Chukwuma Mwaya. He said, Nigeria is sitting on a ticking time bomb. I've left the link of this write-up in The Guardian, okay? Please, I will beg that you click on this link. We'll share this. You click on this link and see what he says, that yes, that these things are creeping in, and he tried to lay emphasis to the same kind of incidents that happened in the 70s when there were predictions that resistance to chloroquine is creeping into Africa. The same way it started from East Africa in the 1974. The same way, the same pattern. Okay? And so we must be on the watch, because we are custodians of drugs and medicine. We are the experts when it comes to drugs, and the best must always be given out. Okay. And so we look at what are the possible reasons. These are all consensus by part of the review and study that we have gathered. That yes, there is deliberate drug counterfeiting. There is poor quality control. There is decomposition due to improper handling of a drug. Instability of a drug throughout the shelf life. Okay? We have suboptimal dosing, misdiagnosis. Prof has talked extensively on misdiagnosis, wrong malaria classification, misinformation. I know I was given 15 minutes, but pardon me, I might stretch that a little bit. And so we say all hope is not lost, even as Greenlife Pharmaceuticals. And that is why we are also here adding value and bringing the right information to us here. And so we present to you today Lonarts as a remedy. If we say all hope is not lost, what do you have? You have Lonarts. And why do we say Lonarts? In the course of this presentation, I'll push that further. So we say Lonarts scatters malaria. We have confined malaria. You and Greenlife have confined malaria in solitary confinement for 19 years. And we are still doing that. And these are the different SKUs. Lonart DS, tablets, suspension, dispersible, and the likes. For 19 years, we have been there delivering trust, delivering efficacy. No treatment failure as you have it today. And so what you see here is our certificate of analysis from the manufacturer. This is an assay done according to international pharmacopoeia. And the assay reads that artemeter of this presentation is 101.1%, and the lumefantrine is 102.7%. You can find this material everywhere. Yes. So they all pass the specification according to international pharmacopoeia. And why do we say this? Because we must begin to ask the right questions. Okay? We must begin to ask the right questions. If you stumble on a pack of a product that quotes that artemeter, lumefantrine, WHO International Pharmacopoeia, we might begin to ask the right questions. Can I go into the pharmacopoeia and see it right there that this is how this formulation is assayed? Prof talked about quality control in Nigeria. These are current certificate of analysis. We must begin to ask these questions so that when those drugs that do not meet the specifications come to you, as custodians of drug, as professionals, we must continue to ask these questions. And so this is our certificate of analysis. And why do we say so? It's done for our tablet. And it proves to say that our drugs meet the specifications the governments are asking. And these are RFQs, also suggesting that even donor agencies reckon with some particular dosage forms. This particular one, even though the name has been redacted, in their quotations, you see that they insist on some specific kind of formulations. And it's very important to begin to pay attention to this. And so Prof shared this with us, but I'll just put more emphasis on it. Even in the current guideline, the dosage form we've tried to highlight, and so that we continue to begin to pay attention to this, that there is a consistency in what the specifications are doing, in what the monographs are saying, in what kind of dosage forms we should be looking at. So we may quickly go back to the basics, okay? Misclassification. We try to ask some people, because when you go to the field, you ask these questions. How do you tell between severe malaria and uncomplicated malaria? You'll be shocked that many people still think that when you have plus, it's uncomplicated malaria, and when you have plus, it's severe malaria. And so when it is classified wrongly, you can also see that the treatment will be wrong. Prof talked so much about diagnosis, and so we say it too, that yes, once there is no diagnosis, when diagnosis is wrong, is poor, you have this kind of problems mounting, treating a disease that is not there. And so we continue to advocate. In June, we brought someone from NIMA, and he trained our young pharmacists on the importance of the 3 T's. The test, treat, and track is very, very important. And finally, you have misinformation. This still happens under our watch. When labels are written like, we don't know what was said, but this is picked up even in urban Nigeria, okay? And this says a lot. Even though our pharmacists, our trained sales rep, go out there and engage our customers on the proper way of labeling. So you see this going on out there. And so sometimes we must bring it to the fore. The Lonart offers a better parasite clearance with enhanced absorption. And so you have the artemeter working in this, based on this pharmacokinetics, 2 hours onset of action, lumefantrine 6 to 8 hours, and we insist that the first dose must be taken 8-hour interval. We insist, and it's very, very important. If this is not done, as gatekeepers of this product, we are not doing what we are supposed to do. And the environmental aspects of what are the drivers of these emerging trends is on our doorstep, on our footstep. If I ask, when was the last time you told a patient to take Lonart, or any AL for that matter, with milk? When was the last time we did that? Lonart offered a very, very high ACPR. And with Lonart, you have, even after 28 days, you have 98, 97, 98% treatment. And even the therapeutic efficacy study that Prof showed us, it showed that even AL is giving us as much as 99% ACPR. And why do we say this? When you look at the backup points that even other products tell you, what do they say? Do they mention the ACPR? And do they tell you how they went about it? So we must continue to ask for all of this. And so, 97% ACPR, and you achieve complete parasite clearance in 32 hours when the drug is taken rightly. And this is what we have come to understand that Lonart offers to us with no major side effect. All of these are quoted copiously. And so we continue to reemphasize that Lonart has been with us, trusted, being the correct anti-malaria, and we'll continue to do that. That Lonart is the pioneer with 6 doses, assured quality. Lonart was the pioneer of the MAS even in Nigeria, where we can prove to you and give you the guarantee that every Lonart you buy, once the scratch card panel has been activated, you are sure that your drug is authentic. And you begin to hear things like, Lonart, the taste, and all that. Sometimes we would like to shy away from this. But the real taste of Lonart, I'll say the taste of success, is the taste of efficacy, the taste of stability throughout the shelf life. And indeed, I tried to do it at the ACPN at Mushin, where I popped out Lonart for them, and I told them can you just try it? Lonart is thin film coated. Yes, there is that smell, but it's not enough to begin to look at other dosage forms. And interestingly, when you take it with milk, the taste is no longer there. So the real taste is not the bitter taste that we complain about. The taste is the taste of success for 19 years, is the taste of efficacy for 19 years, is the taste of the stability throughout the shelf life for 19 years. And that is what we propose. I'll just briefly talk about the cousin of Lonart DS. The cousin of Lonart DS is P-Alaxane. And when our reps come to you, you hear things like the 60-60 anti-malaria. And there's this question around what is this 60-60 anti-malaria? So we still try to lay emphasis on one anti-malaria that you have, that the onset of action starts in 60 minutes and gives you prophylactic cover for as much as 63 days. Okay, so when you hear 60-60, what are we saying? We say you take the first dose, okay, and in 60 minutes you start getting effect because the molecule in the compound is dihydroartemisinin. So you start getting your effect from 60 minutes, and by 63 days, you still have the piperaquine in system trying to mop up any leftover of the parasite. Finally, I know I've said a lot in this very short time, and so we have a lot to do today. So I'll leave this QR code here for you to scan, and let us get your feedback. And in conclusion, I would just like to say this, that we say this in the spirit of public health advocacy, that yes, there's an emerging threat of resistance, and we have been educated copiously on that today, on what are the things we must look out for, and what are the things we must do. After engaging with Prof, he said, okay, that even is going to still send his conclusion to us via email. But we want to leave you with this, that the spirit of what we are advocating is that we begin to ask these right questions. Okay? This drug you're bringing to us, it is specified by the official books. Where's your certificate of analysis? Lagos State is leading the march of universal health coverage right now. They have been asking these right questions. You can't make supply in Lagos State without first tendering your certificate of analysis. Can that begin to happen even in community outlets so that we know exactly what we are dealing with? Yes, it might be so much to ask for, but we must begin to ask the right questions. Now, what is the therapeutic efficacy of this drug based on the last study that was done? Prof said they do it every 2 years. Can we lay our hands on the current document and begin to ask? Thomas Jefferson said something. He said the Constitution of America is so beautiful, but there's a spirit behind it. And this is what every American knows, that there are 3 unalienable inherent activity, spirit that backs up this Constitution, that every American, I'm not an American, if every American has the right to life, the right to liberty, and the right to pursue happiness. And that is the spirit. So everything the Constitution says, it must go by that spirit that it protects the right to life, the right to liberty, and the right to pursuit of happiness. In 1972, in conclusion, Soyinka said something as part of his memoir coming out of prison in his book titled And the Man Died, okay? He says the man died when he stands in akimbo in the face of tyranny. We are not going to watch these trends continue to emerge. It's in East Africa, just the same way in 1974. It's creeping into Africa. We must take action. We can't sit idle. We can't just watch. We can't just hear this lecture. We must take action and insist on the correct anti-malaria and insist on the best anti-malaria that has stayed with you for 19 years and will continue to deliver quality to you. I'll leave you with that as my conclusion. Thank you very much for the opportunity. Thank you very much for your audience. And continue to recommend and advocate Lonat. Okay.
Some of us online who are asking some very... Adi? Yes. Put the PR code back. The PR code.
Okay.
The code.
Mr. IT. Yes. If you permit me, there's a question online asking about the RDTs. Though I work with Greenlife and I don't speak for RDTs, but from what we are also gathering, that once a patient comes in and the RDT test is this very simple test for the person asking online, and within minutes, the result is actually out. Okay? The person doesn't have to present with febrile condition before, okay? If he has mentioned at least 3 or 4 clinical symptoms of malaria, with or without febrile condition, the RDT should pick out if there's malaria. And then the second question.
Tosin.
It's a Tosin.
Second question.
Okay. Yes. That everybody in the malaria endemic region must have at least 1+ malaria in them. We hear this a lot. I have heard this too. Okay? I don't know what reference to make to it. We'll be happy to know that there's a reference, a study that says that. But beyond that, I can only say that we and malaria, we have come a very, very long way. So whether you carry 1+ malaria in you, it might just be a myth. We need to do a microscopy. We need to do a diagnosis to say that, yes, you really carry the parasite. That's how I would respond to that question. And even though I'm in the front of very distinguished, learned and pharmacists, other people can share their views on what they think about those questions.
All right, do we have questions? Questions, comments, and contributions. We recognize the presence of pharmacist Mrs. Chief Yetunde Morondia, FPSN, and the Vice Chairman of BOF. You're welcome. Question? Please come. Please, before he takes the microphone, the BR code, have you scanned it? Just look for a Gen Z seated by your side and ask for support. Please, this website, you can also go here. Here is where you have the questions. You have the questions. The fastest finger goes home with something beautiful.
Just a simple question. When you are displaying the test, the result, the assay of the Lonat and your anti-malaria, is it every batch that you test? That's once a batch is finished, you manufacture another batch, you take it to the lab to test, or it's just once and for all? That's the simple question.
Okay. Yes, thank you. Okay. Yes, thank you very much for that question. Yeah, and that's why we put it out there. Every batch of Lonat that we have in our system, we always, firstly, because we do not know when the LPOs will come. Okay? So we do certificate of analysis of every batch of our artemether-lumefantrine. Because if the LPO comes at a time when you have not done any, you might begin to chase the wind. So we do it for every batch of our artemether-lumefantrine, of our Lonat. Yes.
Yeah, thank you, Farm Henry. Yeah. Not only we do it once, but we retain the samples, right? So it's every 6 months. So say, for example, batch number BR203, okay, we produced, and then keep it for the accelerated stability study. So meaning that the shelf life is 2 years, so every 6 months we bring it out, 1 pack of that, and do the same study. Yeah, so that it did not deteriorate over the time. So we can assure you that every batch is not, at least 4 to 5 times it get tested during the shelf life. So thank you, Farm.
Thank you. Yes, thank you for adding that to the mix, yes.
A big one for Greenlife. A big one. Are you sure you can check the website? All right. Please, it's time for tea break. And we'll just allow our leaders to go forth. Then after we follow in a very... You see the way the malaria parasite behaves now. Very organized. Malaria parasites are very organized. So please, let us also follow their style. And let us be organized. Thank you. All right. We are looking at possibility of bringing the tea to you so that you don't mutate. Is that okay? We just finished Masterclass now. You can mutate, you can... What is again? They say I live in Ogudu State. I have to look for where to... Maybe I should go to Oshu. I should move to Oshu State. Come on, that's call your new report here. Why Lagos? I just got one beautiful counsel now. I've been advised to go and set up a pharmacy in Sambisa Forest. It will be very lucrative. Oh. Who will go with me? Who will go with me? Who will join me? Let's go. We will be the PSN there. We will be everything there. Chairman, let's go.
Good afternoon, everybody. Allow me to stand on the existing protocol. It's a nice afternoon this day, and I want to draw your attention to something. Yeah, the slides, it had a bit of an issue, so they are doing it, but I was not really prepared for the slide. I want this session to be interactive because it's a practical thing that I've been doing for many years, and that was why NewHeights Pharmaceuticals intended that, no, I must give this masterclass. By way of introduction, my name is Mr. Pedro Ebomese. I've been a pharmacist for more than 20 years, and one of my core interests is in point-of-care testing. As I said, I want it to be interactive, so you can actually interrupt me if you need to ask any question, because it's really, really an interactive session. First of all, point-of-care. I tag this topic as the next generation of therapeutic intelligence. The next generation of therapeutic intelligence. Yes, I was given a topic before, but I looked at it that no, it's not going to do justice to this interactive session. So I remodeled it and called it the next generation of therapeutic intelligence. And as an introduction to this session, point-of-care test can be performed by any healthcare professional. And the point of reference here is who? Pharmacists. It can be performed by anybody. We are even technicians in emergency care. They do this test, and it behooves us as professionals that we should key into this point of care testing mechanism. We would like to know, please, how many of us have actually, or we are involved in this testing in our premises? A show of hands, please. Thank you very much, ma'am. Thank you very much, sir. So, the concept of point-of-care testing is a rapid turnaround of test results for treatment outcomes so that your decision concerning this patient will be very, very instant. And the role and benefits of point-of-care tests include reduced management time, quicker clinical decision-making, rapid idea about critical patients. And when we say point-of-care test, it cuts across every machines you use in your practice. Blood pressure monitoring machine, sugar test machine, and the recent one now, COVID-19 test kits. It cuts across all these things. But now, we want pharmacists to be more, because I've noticed it, and I've done a study about it too. I discovered that no matter how critical a situation is in the community, they run to you first. Why? Once there is an issue in the society, I've seen a lot. They come to you first. That shows that there is this confidence. The public, they've put that confidence in you that you can do everything. When the other speaker was speaking in the masterclass, he was saying something about when you see a patient for the first time, the first thing, your pharmacokinetics, dynamics, everything comes into operation quickly. And you are trying to make a decision for a patient. Now, at this point, we now see why the point-of-care test mechanism is very, very critical to our practice. There are 5 points of point-of-care tests. One of them is safety, dignity, independence, privacy, and communication. And this is where your communication skill as pharmacist really comes into operation. Because I've noticed over many years that your capacity to pull in patients into your practice, because they are coming to you, they are afraid. I'll give you a case study. As I said, this session is loaded with case studies, and that's why I have my case study book with me. It's loaded with case study. For example, I had a patient one day, we were about closing actually, and he ran into the pharmacy. We were like closing. I was like, what's the problem? We are closing. He said, no. When he gave me the whole sequence, I said, you need to be in the hospital. Let them do that. We are closing. Not as if we can't do it. He said, sir, going to the hospital at this time is late. That was around 10 o'clock in the night. It's late. And if I don't get this done, that he just Googled it right now, that he's in trouble. Okay, what was the issue? He had sexual contact with a lady. And after the sexual contact, the lady told him, I'm HIV positive. And the guy was like, the guy was like, he's dead. Initially he thought the lady was joking. And it's so funny. These are the things we see. And that's why I actually brought it to this masterclass. It is so funny, but it's real and it's out there. They won't come to you if they don't notice this trait in you that, yes, you are able to help. And over a period of years, I've been able to do that. So they now understand. So he came with the lady. And I'm like, are you for real? She said, yes. I had the point of care with me, which is the one, we are going to talk about it. That's it anyway. I'm going to concentrate on it, but when the time comes, I'll concentrate on it. So I did the testing for the lady, and it was positive. I did the test for the guy, it was negative. So what's the best option? Post-exposure prophylactic treatment. So we gave it to the guy. So every month, he kept checking. Until the 6th month, he checked and he discovered that it was okay. Now you see the therapeutic intervention that was done that very day. So that is where the point of care testing really shows prevalence. Thank you very much. Thank you very much. Hello. Well, as I said, these are products, something you can actually look at. My focus is on that. My focus is actually on that. So we can just scroll them. These are other kits, point of care test kits that are available in their profile. But my attention is actually on the viral hepatitis test kit. Thank you very much. So you can, as I said initially, you can actually deploy these devices in a lot of settings. Your sugar test kit, hemoglobin level kit, HIV test, pregnancy test. And talking about pregnancy tests, I want to go into that also. It's one of the kits they have in their, with them. Deployment of the pregnancy test kits. It actually uses urine. But for the purpose of this masterclass, I can tell you for free, it can use blood. I don't think they know, but I was able to discover this because I did a training on family planning. I was trained on family planning, and one of the bases for family planning, if a lady walks up to you that he wants to take up any family planning, the first thing we want to find out is, are you pregnant? And a lot of them, I can tell you, a lot of them will tell you they are not pregnant, and they are pregnant. And the first thing the idea they were giving was, if you take this family planning stuff, it will abort the baby. So they'll come to you and they will tell you they are not pregnant. But with the test kits that is marketed by NewHeights, they are pregnancy test kits, it's like a cassette. You use urine. Urine is the standard procedure for using it. But because of my training in family planning, you can use blood. And once you use blood, it detects it as early as the day the lady missed her period. And on the funny side of it, I was trying to do family planning for a lady one day, and the trainer said, do pregnancy test for the lady. I said she's on her period. Do pregnancy test for the lady. Ma, she's on her period. How did you know? She told me. She repeated it the third time. Do pregnancy test for this lady. I said, okay, if you want to embarrass her, we'll do it. She's married. You can see that. She said, still do it. And that was the kit I used. I did it. I used blood. If you have used urine, it will fail at that point. Because, I used blood and it was positive. It was positive. Thank you. If I give you this information, $100, you give it to me. All right. Yes. The pipette that is included in it, take that volume of blood, put it in that, no matter the volume of blood you take. Madam, should I tell her? Should I give her the information? Just use normal saline. Use normal saline. Add it to it to develop it.
Just add normal saline. I've already asked the question.
Thank you very much. So we can go. Oh, they said they didn't hear you, please.
Okay, the question I asked was that using that pregnancy test cassette, there is always a pipette there. So with the pipette, you pick the urine, and most times it's almost like 2 ml, 1 ml to 2 ml of urine that you pick and put on the cassette. So when he says that you can use the blood, so my question is, what volume of blood? But he has answered it, and he said that you can actually use the normal prick method, drop the blood, and just dilute with normal saline, so it will still give the results.
All right, so immediately I checked it. So the trainer told me, don't underestimate what you are doing. They come with information that is clacking, but not all the clackings. They don't give you all the information. So within that period of time, I was able to gain a lot of information, got a lot of things. So that's when I now started increasing my usage of their test kit, because it is very, very sensitive. There are 7 C's in caring when it has to do with patients. There is the compassion, the competence, the confidence, the conscience, the commitment, the courage, and the culture. Then communication. The courage has to do with your ability to see a case and you don't shake. I saw a practitioner one day. I was inside the consulting room and the lady was telling him some things and he was cringing. I was like, where did you have your training? You're supposed to have that courage. You're supposed to, now you have to understand your culture. Your competence as a pharmacist is what people run to. And that's why they will bring a blood pressure of 250 over 150 to you and believe that you can do something. They will bring it to you because over time they've seen that competence in you. And the more you build it, the more case studies you have as a pharmacist. Now, the beauty of the NewHeights Pharmaceuticals point of care test kits are many. They are very sensitive. I've been using them now for many years. They are very sensitive. Sensitive as in sensitive. And the volume of blood or any other thing you want to deploy for that test is always minimal. And for the 3H viral test kits, one thing that comes with it that I love is that it takes care of hepatitis B, hepatitis C, and HIV. So, over a period of time, because the community where we practice, they are knowing this, they've started now coming that, okay, well, and mind you, I discovered something. No matter how well universal health coverage is going, a lot of private patients, they still need their thing done their own way. And that is where you come in. Another case study I would like to present is the case of, or let me say the deployment of their test kits. It's also in drug therapy. Drug therapy. I'm not coming into the place where you start deploying these test kits. The sensitivity of the kits, you can find that out by yourself. Just purchase it and use it. You'll be shocked. Very sensitive. And they've really done a lot of job on it. But I'm interested in our pharmacists actually having this capacity to deploy these things in their practice. First of all, their homegrown machine. I have the manual one in the office. And most times when I see a blood pressure that I'm not comfortable with, I use the manual immediately to check. And I've always discovered that they are the same. Also stressing that point that their machines are really, really very sensitive. Also, the deployment, as I said initially, that we can start using this point of care testing kits for. Case study 3 now. I met a patient. She came to the pharmacy and she wanted Atrotech. She said she doesn't know if she's pregnant or not. And we all know the misoprostol in Atrotech can actually bring about an abortion. So she said, how do I know if I'm pregnant or not? I asked the missed period and everything. She said she has missed her period, but she doesn't feel pregnant. Simple. The pregnancy test strip kit. I used it, checked the blood, and it was positive. So she didn't use the Atrotech. For the pain, she needed to now use other option. Also, some other patients will come in. I don't know if I am pregnant or not. The same deployment. Use the blood, the test kit for the pregnancy, and we use it, and they are not pregnant. So you are free to use the Atrotech because it has misoprostol. Then, on the other side of it, there are a lot of ladies too that want to come and tell you that I'm not pregnant, but I need this medication. As a pharmacist, we already know drugs that will predispose women to spontaneous abortion. So one of the ways I've deployed their kits is if you come in and you are buying a particular kind of drug, I will insist that you do a blood pregnancy test. And 35% of the time, the lady is pregnant. 35% of the time, the lady is pregnant. That's what they will not tell you, actually, please help me. I really want to take this thing out. And a friend advised me that if I take this, it's going to happen. So those are one of the ways we have deployed this test kit. Another way we deployed it is patient misinformation. There are patients that come and they have this misinformation. Like somebody that actually almost committed suicide. He came to the pharmacy and I used the 3H viral test kit and it was hepatitis B positive. So I counseled him and the rest of them. He went back and somebody else called me that he was in the process of committing suicide. So I called him back to the office. Why is he committing suicide? He said he went online and he discovered that hepatitis is even worse than HIV. So he believes that nothing can be done. He needs to take his life and the rest of them. So that's where the misinformation comes in. You can use the kit right there and start counseling the patient immediately that this is what you must do. Check your family. If nobody is infected, let them go for the vaccine. You are protected. Protect your liver and the rest of them. And the kit also can be used in an all-in-one medical care. You are seeing a patient. You are making your decision. You are seeing a patient. You are trying to look out what are the shortcomings this patient may have. Like many a time, when I meet patients in the pharmacy, I want to look at them very well. A lot of them, they give you misinformation because they are afraid. They can't go to the hospital. They can't go to the hospital because they feel the nurses, they have their information, and their health keep deteriorating. But with this point of care test kit, depending on the one you are deploying, you are able to now counsel them, advise them, and give your necessary pharmaceutical care as required. Then, also, I put something here as marital intervention stroke relationship. A lot of people now come to the pharmacy and they are like, we want to start going out. We want to know our status. We want to start going out. We want to know if we are good to go. Those are places you can deploy these medical devices. Then, disputes. You can use this test kit for dispute resolution. I'll give a case study again. I think there were like 5 people. They came into the pharmacy. I was like, what's happening? A lady was with them. The other 4, they were men. I was like, what's the problem? They said the lady is insisting that the man is responsible for the pregnancy. I was like, you go to the police station and deal with her. They said they are just coming for the police station. Policemen actually drove them out of the police station that they have gone to general hospital and they don't know what they are still looking for. But they insisted that the guy is not responsible for the pregnancy. Now, the beauty of this thing is that the lady refused blood tests in a general setting. She said she's not going to do blood tests, but that the man is the one responsible. So, as I said in my previous write-up, competence, courage, your ability to communicate. So I discussed with the lady. I said, see, this is what is going to happen. Let's do it. You can't go to the hospital because of the disgrace or anything. I can do it right here in the office. She was shocked because she wasn't expecting it. I have a kit. I will use it right here for you and we can make our decision. Make 1 or 2 calculations. So reluctantly, she agreed. And when I did it, it was negative. They almost fought in the pharmacy that day. As in seriously. They almost fought. It was serious. I had to plead and plead and plead. The girl was never pregnant, but he was using a cultural cycling of the guy to make sure that the guy marries her. Please, moderator, please. So if my time is getting close, let me know. Thank you. So, in all these cases, I discovered that we the pharmacists, we have a lot of job to do. Both a lot. Because on and on and on and on, the patient keeps coming to you. I don't know, maybe because over the years they have built this confidence that their information is safe with you. Everything about them is safe with you. So they tend to come. So as they are coming, you must build your competence. You must build your knowledge. You must build everything that you need to deal with every possible situation that will come up. You see children coming, parents coming to the pharmacy with their children. Their blood is down. Why are you buying blood tonic? The blood is down. And you see blood tonic that will solve it. If you have your HB, your hemoglobin measuring, you can do it right there and prove to them that, okay, it's actually down. It's because you have to save them from overuse of iron. A lot of skin reaction you see in children is as a result of overuse of iron, multivitamin, iron syrup, and the rest of them. You put the patient into more trouble, thinking that you are trying to build the blood count of the patient. Private cases abound in community pharmacy. A lot of private cases. Well, they don't have names, so I can actually relate 1 or 2 of them. Private cases in the sense that, what is my status? What is my status? What should I do about this particular thing? What am I going to do if I find out that I am positive concerning a particular thing? That's where you come in. Your communication skill, very, very important. And you're able to bring in this patient, like the other case study I said the other time, like there was a day a couple walked into the pharmacy. The man was virtually crying. I was like, how can a man be crying in this century? Very important. Very important. So she came in with the wife and I asked the man, what's the problem? She said she's HIV positive. And she had been hiding it from the wife and they have been having sexual contact. But yeah, one of the places I talked about has to do with conscience. And he said his conscience is no more allowing him. So he had to tell the wife and they came. The man was visually crying that something should just happen, that the wife is not positive. And they said they know they can't do it in an hospital environment. They need somewhere they can talk to, interact with. Because mind you, there are many people that commit suicide when they know their status. I just gave you a case study. So I checked the man, positive, yeah. And I checked the woman, negative. Not 1, not 2, not 3, many cases. That's a story for another time. Why is the man positive and the woman is negative? Why is the woman positive and the man is negative? A lot of reasons. Anyway, not for this masterclass. So, in that light, you see you look at your position as a community pharmacist, your ability to really do a lot of things with this 3H viral test kit. As I said, this is just a point of call because of what it carries. Hepatitis B, Hepatitis C, and HIV. You check it right there and you make your decision. And you are able to help your patient to have a better life. At this point, because of my time, I will want, as I said, I want it to be interactive. I want us to go to any discussion, any question. Any question, please? No question. Please, microphone.
Thank you very much for the insightful presentation about point of care. From discussing with some colleagues, the issue that comes up has to do with ascribing a cost, an economic value to those services. So how has it been? What's your experience like? Because I'm imagining that a test for DNA paternity might be very, very expensive. So how do you...
In the deployment of the POCT devices, one of the things I talked about is private care. And in private care, I like talking in between people. Okay. In private care, you have more patients in private care that want things done by themselves. So, let me check. In all the patients I've asked to use these kits with its cost, I've only had like 8% rejection out of 100%. Because most time when they are coming, you see, they are coming with, they need a solution. Do you understand? The person that took the Masterclass on Lonat is expensive compared to other anti-malarials. But I've discovered one thing in practice. In short, kudos to pharmacists. I discovered that any anti-malaria that a pharmacist brings into the country, as in personally, not for anybody, brings in, they are good. So if you come to our premise, you might hardly not see the popular brand. I go for any anti-malaria that a colleague brings in. And I keep doing, and I will keep doing it. I keep doing trials. I can take your piperaquine artemeter, give it to a patient, and give another brand to another patient. I see their results. And I discovered that, like a colleague of mine, he actually brought in fluconazole into the country. And his one was expensive. There were fluconazoles that were so cheap. And I asked him, he said he took 3 samples from the market, took it to the lab. One was 5 milligram, 8 milligram. The highest was 12 milligram. He said his one fluconazole is 50 milligram on the dots. And when they did the analysis, which is submitted, he showed me the evidence. NAFDAC actually saw 52.5 milligram in his own. So you have therapeutic success. So the patient is not, except a patient is not tired. By the time they are ready, they go for the best. So as I said, I've only had 8% rejection that, okay, it's too expensive. 92% because they need results. And result is the basis of therapeutics. If there's no result in therapeutics, your therapeutics is 0. So for the cost, I don't even go there. We are only begging them that they should temper justice with mercy. But for the cost, no. They always get it right. Because whatever you get right, like some patients, when they come, they will say they were HIV positive. When I use their kit, and they are negative. So where did they get the positive result from? Why some that they say they are negative when we use it? So over time, I've just developed this system by which I can use their kit. And gradually now, for my community, because they are now exposed to the kits, they start asking, okay, I did this test. Let me confirm with this. Because over time, they've built that confidence on the. So that answers the cost issue about POCT devices coming from them. Thank you very much, madam. Sir.
Any further?
So thank you, sir. In fact, it was a wonderful presentation. NewHeights Pharmaceuticals, yeah, they're giving, serving the society with very innovative products. So congratulations, kudos to you. Yeah. So I just wanted to know, you mentioned something about the pregnancy and the pregnancy detection, whether it is, his child, that child. What technology does it use? Does it use DNA?
Okay.
Yeah.
Since it's not, it's a case study.
Yeah.
I didn't want to really expatiate on it. We were talking about early detection of the HCG level in the female at that point. Now, the female insisted, because, I asked the lady, when did you have sexual contact? This is the date. When did you miss your period? Now. So, if we do a pregnancy test, if it's this guy, to be positive. And the lady was like, okay. Now, most of the time, the POCT devices, they are coming as a surprise to people when they come to your pharmacy. They don't expect it. They are not expecting it. So, they are trapped. I will need to do this. So, you insisted that this guy got you pregnant. And from the calculation, I expect you to be positive by today. So, we used it. Now, she said she have done urine tests. And it's negative. He told the guy that he is positive. And I said, okay, let's use blood. So we used blood, and that same day, it was negative. So that was how the guy was freed from forced marriage. Any other question?
Your pharmacy is like okay today.
There's a hand there. There's an hand there.
Yeah, good afternoon.
Good afternoon.
Yeah, I just want to ask that for the test, the case for the HCG, that after the urine sample must have been used and it comes out negative. No, negative now. I just want to, it comes out negative. Can you still go ahead to use the blood sample?
On a different kit.
On a different,
yes. The reason for
which one will you advise first, the blood or the urine?
Depending on the case. Like as I said, I am a family planning provider, and we do both non-blood and bloody procedures. For the bloody one, yes, those are one of the applications. For those that do family planning, because I'm going to do Jadel, Implanon is simpler. Because I'm going to do Jadel is a bit more bloody. I must know your status. And one of the points of care you must look at in patient is that telling them, go and do this test, go and do this and come back. They will disappear. There are a lot of things. So with your kits with you, okay, you want to do a Jadel, okay, fine. I have to do a pregnancy test. I have to do HIV, hepatitis, everything. I know I'm going to be touching blood, so I'm going to do that. A whole lot of other tests. So right there, you are doing it. You are taking the decision on what you want to do right there. That's one of the advantages it affords. For the pregnancy, why we started deploying blood was my training in family planning. Sometimes the urine is not just there to give you that because of the level of the HCG. So, actually, it was a nurse in the family planning clinic that taught me that you can use blood. That they used to catch a lot of females when they come and they want to see, make you do a procedure when you are not supposed to do it. So, that's when I deployed it. I found out that, wow, you can use blood. And those that comes with urine, with their strip, negative. When I do use their own kits, and I use blood, it's positive. And always they will tell you that they are aware. They just wanted to force your hand. Maybe if you give them this, they will. abort the pregnancy. So those are my experiences. Okay.
Good afternoon.
Good afternoon, ma'am.
Thank you, sir, for the beautiful presentation. So my question is there any point where this point of care kits come in handy in hospital pharmacy, or it is just an intervention basically for the community pharmacies?
Thank you very much. One of the universal basis of using point of care test devices is to find out on the spot. Is to make you make a decision. So hospitals are meant to be using it. Pharmacists are meant to be using it. Nurses are meant to be using it. Now, if you look at the way it was made, you can actually use it at home by yourself. But because our society is still unlearned, they will see, even when they buy it, they will still come back and say, I don't understand how to use it. Use it for me. So that's the point. You now have to have all your competence, your safety, your gloves, everything. Put it in place. So it's not just meant for an hospital use. It's meant for any health institution.
I'm sorry I need to come up again. So just to follow up on your response just now, I thought in the hospital setting, okay, there's a need for demarcation of services. What I mean is, in the hospital setting, the physician is to diagnose, the pharmacist is to dispense medication and probably make interventions, then the nurse is to administer. So for me, I think I was thinking that there could be conflict if as a pharmacist you're deploying point of care test within your pharmacy. Can you elaborate on that so that we don't, thank you.
To answer that.
There is a lab department there.
There is always a lab in the hospital, so you don't need to do any tests in pharmacy.
Claire?
All right, okay. No further questions for him? All right. I hope we do understand perfectly what he talked about. Can we give him a round of applause? Sir, okay. Let's, you will clap.
Thank you for the enlightening presentation. I want to ask, how much do you charge? I know the charges are relative. The charges are relative, but I want to know average of what you charge. Extra, apart from the price of the kit.
When we do a general markup for the kit, you do a general markup that involves your glove that you are going to use and the kit. So once you are buying the kit, it's a community service. We'll do it.
All right. Community service. Okay. Is there anyone where you can mix the urine and the blood together?
No.
So you can go, sir. Thank you very much.
Thank you very much for having me in your space.
We still have New Heights on the table. We have Madam Joy, who is bringing joy to the table. When I see ladies, I always like them walk in royal majesty. So please, we can here now. You just walk majestically, all right? Let's give her a round of applause as we take a session.
Good afternoon, distinguished pharmacists. My name is Joy Ide Malaria, a representative of NewHeights Pharmaceutical. So, Farm Pedro has actually done the Ide Malaria. So Farm Pedro has actually done the practical aspect of what I'm here to do, but I just want to pick out and emphasize on the unique selling points of those products. There are so many kits in the market. What makes New Heights kit stand out is what I just want to talk about.
So the practical has been talked about already. So first on my list is reduced wait time, results as early as 4 days after conception. Like the usual and the regular brands in the market, for HCG to be detected, it takes like 2 weeks, 10 to 14 days for HCG to be detected. But for health check, pregnancy test kit, and a conception kit, it detects conception after 4 days. After 4 days of conception, it detects HCG level. Why? Yes, 4 days after conception. There is a mechanism, there's a reason why it does that. After fertilization, once there's a release of HCG, it picks it. So immediately there's a fertilization and HCG is released into the system, it picks it. So that's why we call our kids ultra sensitive, and it reduces waiting time. Because for a woman, okay, let me share you a story. This is a life story. It's not because I'm selling this kit. So a lady took the regular pregnancy test kit, checked, and she was negative. At the end, she took chloroquine. Yes, she didn't know. She had been taking chloroquine before, now it works for her. So she took chloroquine. When she gave birth to the baby, the baby had cleft palate and cleft lip. She could not, there was no difference between, she didn't know, is it the mouth or is the nose? She didn't know where to put the nipple. So she was confused. And they began to ask questions. What happened to this baby? So they began to trace back at the time she got pregnant. So initially she didn't know she was pregnant. So after she was taking it, later on, she was still feeling sick. She went back to the hospital and she detected she was pregnant. So she didn't know that chloroquine had an effect, a congenital effect on the baby. She didn't know. So when she gave birth to the baby, she realized that. So if a woman like that had used this kit that will show you detect as early as 4 days, she wouldn't have had that irreparable damage that was done to the child. But thankfully, there was what we called Kano Foundation. It was Kano Foundation that helped her. So they operated the baby within 3 months, 3 times. And they took part of the flesh and fill up the mouth. The boy should be like 14 years now. And he's fine, you will not know. It's just a little mark here that you would know. I would have shown the picture if I really wanted to, but God of time. So it detects, okay, I don't want to go through. So ultra sensitive. Detect HCG as early as 10 milli international units. When you compare to other brands, they do 20. So ours detect as early as 10 milli international units of HCG in the system. That's one of the unique selling points of our product. Then it uses blood at any time of the day. Then it's easy to use. It's 99% accurate. Many pharmacists have been using this and they can attest to the fact. So both the pregnancy kits and the conception kits. The conception kit detects HCG too. But the difference between it is that this one, you take in the blood and the urine sample with a pipette into the sample hole. But for the conception, you use it it's just like a pen. You open it up, there's a sensitive area. You allow the first urine to move out, then just allow your urine to touch that sensitive area, place it on the surface, and the result is out. So that one is very convenient to be used. Even in your office, in case you want to check, you can check while at work. It doesn't, no much technique for that one. It's easy and convenient to use, but it do the same work. But for affordability, this is more affordable than that one. So for some pharmacy, they prefer that. Some pharmacy also prefer this. So for our fertility check, I don't want to go too much on this. You already know all of this, luteinizing hormones. So, but where I want to speak much about is the tips for testing for our fertility. Most people do not know that 2 hours before you test for luteinizing hormone, reduce your liquid intake. Whether it's water, it's juice, it's tea, anything liquid dilutes luteinizing hormone. So someone can actually be ovulating, but because the luteinizing hormone has been diluted, the person will have a false negative result. And meanwhile, the person is actually ovulating. So that's one of the precautions we should take when we are testing. Then, luteinizing hormone does not appear at the early hours of the day. From research, it's from the midday. So for a woman who is checking for ovulation, wants to know if she's ovulating or not, early morning check might be deceptive. You might check and it's showing negative, but when you check from midday, from 11 a.m. down to 10 p.m., that's the right time to check for luteinizing hormone. So for a woman, before you do your check, you should know your cycle. Either it's 28 days or 30 days cycle. So that's the tip you need to know. Then what's the unique selling point for our own brand? It's midstream, the same way the conception works. It comes like a pen. You open up the pen, then you urinate on the sensitive area, place it on a flat surface, and the result is out. So for a woman who has been told by a pharmacist, now we are sharing the information that luteinizing hormone does not appear at the early hours of the day. So now, for a woman who is going to work, she's rushing to work, she cannot check in the morning. So she needs to take this kit while at work, go to the restroom and check. So in the restroom, it's very convenient. You don't need pipettes, you don't need collection cup. You just urinate on the sensitive area and your result is out. The detection limit is 30 milli international units for the luteinizing hormone. It's accurate, convenient to be used either at work or in the house. So it's a home kit for those. Hello. Again. Okay, for those who want to check at home, it's very convenient to use. You can use the manual also. Okay, now, I do not want to talk so much about hepatitis because we all know about it. Hepatitis is the inflammation of the liver, as you all know. This virus attacks the liver, and liver is the site of metabolism. So if the liver is already damaged, what will happen to the body? So drugs will not be broken down, food will not be broken down. So that's the reason why we are trying to emphasize that people know about their status for hepatitis. We are advocating for tests. Know your status. If you are negative, please go for vaccination. If you are positive, go to the hospital for proper management. Having hepatitis and early detection is not a death sentence. If you detect it early and you are properly managed, your lifespan will still be protected for you. It's only when people don't know. Most people actually know their status in a gathering like this. On Friday, we'll be doing health screening. They don't know anything about hepatitis. At the point where we're doing the screening is when they now feel like, oh, madam, from the test carried out, I noticed that you are positive. Do you know about hepatitis? Say no. So it means that you can't even have a trace of when they contacted this viral infection. But if you as a pharmacist, healthcare practitioners, keep talking about hepatitis to people who are around you, church programs, we talk about it. When we go for outreaches in the market, we talk about it. When we come for gatherings like this, we talk about it. The message of viral hepatitis will go viral. Even the market woman knows about HIV. Everybody, HIV has a stigma. If I come into a community now, I say, I want to do HIV test. I say, no, don't worry. Is it something I can take home and do? If it's not, don't bother. Why? If it's positive, there's a stigma. That bros is positive. Oh. My children don't go to their house again. Their father is HIV positive. That is the reason why people run away. But hepatitis has not gotten to that level that people become so conscious of it. That's the reason why we are saying, healthcare practitioners, we need your help. We too, as distributors, will do our own part to make this kit available. But you too have a part to play by creating this awareness. Many of you have social media platforms where you talk about products. Still talk about this disease condition for people to know about it. There are 5 strains of this hepatitis, A, B, C, D, and E. But the ones that are prevalent in Nigeria is B and C. And C, thankfully, when you contact hepatitis C, there is a cure. But for B, there is no cure. It can only be managed. So sometimes we as healthcare practitioners, some people who are actually doing community pharmacy talk about this and they do the test. But what about our family members? Why do we sideline our family members? Can we all boast here that every member of family has been vaccinated for hepatitis B? Is there anybody here that can say every member of his family have been vaccinated? If there is, okay. 1, 2, 3. Okay. 4. Out of the whole lot. It means that we have a long way to go. We have a long way to go. So for the statistics, okay. So for the statistics, we have that 8.1 of the Nigerian population have hepatitis B, and 1.1 of the population are infected with hepatitis B. Then globally, we have 354 million that are already infected with this viral infection. And Nigeria stands at 26% of this global total. It means that we have a lot to do about this. And right now, please, I need your audience. Please, I need your audience. Thank you. And right now, WHO came up with a strategy. The strategy that WHO came up with is that by 2030, we want to do 90% of testing and reduce death by 65%. WHO alone cannot do this without the help of the healthcare practitioners and also the pharmaceutical companies making these kits available. No matter how we want to push people to the hospital alone cannot do this for us. You have a role to play. I have a role to play. Hospital also have a role to play. So for us, as of last year, statistics shows that WHO strategy has only achieved 10% of what they want to achieve by 2030. And 2030 is 6 years from now. And they've only done 10%. So please, my dear pharmacists, we have to do this together. Let's keep talking about viral hepatitis, increase the testing in your premises, and those who are negative should go for vaccination. Those who are positive should be managed properly. So there's something we need to know. Hepatitis B virus, do you know it can live outside the body for more than 7 days? Yes. If there is a blood spill, it's even more. Let's say there's even a blood spill here and it's not properly cleaned. It's going to be alive here till 1 month. So God forbid I have an open wound and I'm just here talking. I can carry it from there. The compound where you live, you're not the only one living there. Should be the gates. Other people are opening the gates. Let's assume there's a blood spill on the gates. You touch it, you have open wounds, and you're not vaccinated. What happened to that person? The staircase, as we are passing the staircase now, everybody is touching the ray, and we are all moving down. You are touching the ray, and somebody who is already infected has touched it. Are you safe? If you are not vaccinated, you are not safe. So what about children that were born by hepatitis B virus mother, and they are not aware, and they are playing with other children? They bite themselves. They scratch themselves with sharpener in the class. So we as mothers, as parents, there are some things that should come to our consciousness. We need to vaccinate all our children. Because children at that tender age do not know anything about it. They can bite themselves. They can pinch themselves. There's blood spill. They can use sharpener while they are using razor to sharpen their pencil. They have a cut. And some of them, when we were small, God have mercy on us. When we have a blood spill, we used to lick our blood. I don't know if people did it. Say, no, my blood will not waste. Oh. Some people even lick their friend's blood. So at that tender age, you cannot be with your children everywhere. We cannot be with them everywhere. But what we need to do is that we make sure that our families are protected. In the pharmacy space, we talk about this regularly. Thankfully, Lagos State, and I know they're doing it that's WHO standard right now, that every child that is born is vaccinated in the labor ward. Right now. I think it's started since 5 years ago. Yes. Any child that is born will be vaccinated in the labor ward. So at least I can say children 5 years and below. Yes, they're already vaccinated. What about those who we gave birth to maybe 6 years ago, 7 years ago? What happened to them? So we have a role to play as parents. So for hepatitis C, there are medications. When you take your therapy within 3 months, you are fine. For now, I think Lagos State last year did it did testing at the primary health centers, hospitals. They made sure that all healthcare practitioners in the government sector were vaccinated. So we too have a role to play. And you too, my company did that for us. My MD called EMZO to vaccinate everybody in our company, tested, and we're all vaccinated. You can do that for your staff. You can do that for your family. You can deduct it from their salaries, just small. Do it. To save yourself. If you think you are safe, what about those around you? So the kit here is the HHH viral cassette. It's the first cassette in Nigeria to detect HIV, hepatitis B, and C at the same time with a single blood sample. HIV, hepatitis B, and C with a single blood sample. So if I take a blood sample, a prick now, and put into the cassettes, add my buffer, it will detect HIV, to detect hepatitis B, it will detect hepatitis C at the same time. There's no cross reaction. And it's 98% sensitive. It's very sensitive. It's a foreign product. Most of the kits we carry, they are from Canada. They are from Atron Lab from Canada. They are very, very sensitive. And you get your results in 5 minutes. So for the malaria kits, in 2015, the WHO reversed their recommendation to require parasitological confirmation of malaria infection before treatment. Meaning that some people will come into the pharmacy space and tell you that, whenever I'm having bitter taste, it's malaria. Don't bother to test. Just give me anti-malaria. And some of them, after 3 weeks, they will come back again. They say that I still have the malaria. I'm still feeling the same way. Good and fine. Some of them might not really have malaria. We are stressed in Lagos, whether you like it or not. Going through traffic in Lagos already is stress. So all fever is not malaria, whether you like it or not. Sometimes there was a time one of my boss, he was feeling sick. He said, this is malaria. I said, sir, you are preaching. We should practice what you preach. Oh, God, we have to do tests for you before you take anti-malaria. You cannot be saying it so people buy your kit. You have to practice it. We brought in the malaria kit, tested him. It was negative. So it's not buy because we have a shop floor and the upper parts. So shop floor, we can buy medication. We told him, sir, we will not buy any medication for you. Take your rest. Go and sleep. Take, water, rest. Take multivite. You have to boost immunity. Take vitamin C. After 2 days, he came back to work. He was fine. Not all fever is malaria. Because drugs are not 100% safe, whether we like it or not. Drugs are poison. So why are you burdening your kidney with things when it's not actually needed? And at the end of the day, you end up having what we call drug resistance. When you keep using a particular class of anti-malaria, over time, it will not work for you again. It won't work again. So the reason why, what are the roles of RODTs? Is to be able to administer the right medication to those who actually need it, not for those who don't need it. Our cassette actually is NAFDAC registered, even though hepatitis B and C cassette, the one I talked about, both Medical Science Lab Council of Nigeria, it has been certified and is NAFDAC registered. All our kits are NAFDAC registered. So our kits right now, the one we have coming, we have a new batch coming, detect malaria parasites at 20 parasite load. So when the parasite load in the blood is up to 20, it gives you a positive result. So we also have a kit that tests for typhoid bacteria. That's Salmonella typhi or paratyphi. It does for the two. So it's also accurate. So the good thing about this particular kit is that you can use a fecal sample. You can use your stool as a sample. If you don't want to use blood, for those who are always afraid to prick themselves, you can use a fecal sample for this to get your results. Huh? What happened? So we also have a kit that tests for H. pylori. Our H. pylori kit. Oh, this is going forward. Okay, this is for H. pylori. It's easy to use and it's accurate. So when people come in and you have the symptoms they share with you as symptoms of ulcer, please ensure you do a test. Confirm it's ulcer, that there's a presence of H. pylori, Helicobacter pylori, before you administer the treatment. Then for the PSA, I wouldn't go all these routes. It's too long. Let me just speak about when people come into the pharmacy space and they say they have difficulty urination, urge to urinate, particularly at night, feeling as though the bladder can't be fully emptied, painful urination, blood in the urine. What comes to your mind? Elevated prostate specific antigen. Elevated PSA level. So what do? We have a kit that can detect this. Our kit detects positive results as early as from 4 nanogram per ml. Once the prostate-specific antigen is 4 nanogram per ml. It shows a positive result. So our kit is a qualitative test. The test kit, what's it called, PSA test in the lab is not cheap. True or false? So when somebody comes in and is suspecting an elevated PSA and does a qualitative test and it comes negative, there is no need for a quantitative. So, because of the cost of PSA tests, it's expensive. I think it's about from 10,000 and above. So when somebody detects this, all the symptoms mentioned can also be a sign of infection. It's not only PSA, elevated PSA that has such symptoms. So for us to be very sure, you have to do a test. So somebody in my church came on, they said, these are the things he's feeling. Doctor said, you go and do PSA, do United test, do that. He checked with the kids. Thank God it was negative. I went back to the doctor and they did a UTI for him, a test. It was UTI. It was not. So if he had spent, he came back later and said, thank you, that if not because you advised me to use this kit, I would have spent 15,000 in the lab. And at the end of the day, I'm negative. The lab scientists will not tell you because it's negative, please come and take your money. It's not true. But this kit, no matter how you mark up, it's not up to 5,000 naira. So at least they can do it comfortably. They can even do it at the comfort of their home. They can do it in pharmacy if they really want to do. So it's NAFDAC registered. It tells positive result at serum PSA cutoff of 4 nanogram per ml. It's convenient to use. Can be used at home. Then for asthma management, I wouldn't want to talk so much about the physiology and the pathophysiology of it. But where I want to speak on is the connection between asthma and spacer device. A spacer device is a simple but effective tool used to improve the delivery of medications from an inhaler into the lungs. It's often recommended for people with asthma or any form of COPD. What are the benefits? It increases medication delivery. Most children don't know how to use inhalers. When they use inhalers, at the end of the day, they end up having oral thrush. Medications end up at the back of their mouths. They start having mouth candidiasis, and sometimes when they talk, it's very offensive. They have offensive. Why? Because they did not use it properly. The medication supposed to go into the lungs is hanging behind the mouth. So, but when you use a spacer device, it helps deliver this medication to the target organ, which is the lungs. Take it down there. So there is no. It helps to reduce the coordination, improves coordination. So when you want to breathe in, some people they're not able to coordinate using inhalers and their breath. They find it difficult when they're using inhalers and then breathing in. But this will help you, give you that space to breathe in the medication down, and it gets to the target organ. It reduces the side effects, which I've actually mentioned. Okay, this for those who don't know how to use a spacer device, this is a video. Please, can you help me play it from there? I don't think it's going to play here with this. For those who don't know how to, can help me play it, please. Thank you. Audio, there's no audio. You can see that it helps the child, the medication move comfortably without stress into the lungs. So let me move to the next one. Thank you. So the unique selling point of this special device is that it comes with 3 marks: an infant marks, an adult marks, and also a pediatric marks. So the pediatric marks, a child marks, and an adult marks. So 3 marks comes with the the device. So anybody can use it, whether an adult or a child can use this device. So thank you for listening. And if there's any question, I would want you to ask any question.
Thank you very much. Questions, comments, or inputs? You did a perfect job.
Thank you, sir. So if there is no question, please, we expect you at our stand. When you come to our stand, we're going to give you, for the purpose of this program, we'll be giving you our ranges at a discounted price, and we also have freebies that come with the purchase of our products. So we'll be expecting you at the stand. Thank you.
Thank you very much. Joy, I think one of the takeaways here will be that between now and the next Masterclass next year, everybody here and their family must be vaccinated. I started my vaccination about 4 years ago. I abandoned it last year. I will resume next year. Is it next year or this year? I should resume this year. Am I going to start all over again? Abba.
Let me say something. You are pharmacists. When you take your first shot, you should complete it within at most 6 months. So after 6 months, if you not complete it, you start from beginning again. And it's not cheap right now. It used to be very cheap. Last year, MZO, I did my own year before my company did it in the office. It was 1,500. But right now it's 8,500 for one shot. Yes. Nigerian factor. Yes. So do not miss when you start. Complete it so you don't have to start all over again. So if you do first shot, second shot, not do your third shot, you will start all over again.
Does he use petrol? All right. So please, somebody should remind me so that I will not miss my next shot. All right. So before we welcome Pfizer, we'll be having a very short discussion. Somebody came one day and they were having So somebody presented with FBS of 519. For me, that was the first time I would see somebody above 400. I saw 519. And can we give a vice chairman a round of applause? She's in charge of the vaccination in Primary Healthcare Board. Elijah, where are you rushing to? Want to clap for you and you're running away. Bye-bye. So, I saw 519. If you saw 519 in your pharmacy, in your practice, what will you do? If you are not careful, you will lose your emotions. And you will do what? You will start crying. My guy said he will start crying. So emotional intelligence is very key. How we relate with our customers, how we deal with them, and in our community. And just for about 10 minutes, we'll have pharmacist Dayo Adetola to give us pep talk on the way we handle our clients. Thank you very much. Let's clap for her. My children came on one day and they said it is let's clap her. Is it let's clap her or let's clap for her?
Good afternoon. Let me say ladies and gentlemen now, standing on the existing protocols. I'm actually not making presentations. What I'm here for is for us to brainstorm just for a few minutes before the next master class. Just to brainstorm.
When pharmacist Okolo from Greenlife was making his presentation, he said he was told at the orientation camp that pharmacy practice has moved from just trying to make profit to patient care. Now, with all the things we've been listening to, how you can carry out tests in your pharmacy shops, how you can do this, how you can do that. Of course, at the end of the day, we expect that this will actually bring in more customers to your shop. But I will say it is not automatic. It is not automatic. There are some things that are also involved. Now, and that is what I'm going to ask us. Like I said, it's going to be, what would I call, a brainstorming session. For example, let's say I went to a commercial bank. I went there to collect cash. Then, after the teller has finished attending to me, I've collected my cash. Then I hand over maybe 1,000 or 2,000 naira to the teller, just to just dash out that money. Why did I dash out that money? Is it because she made first class in Uniben? No. I'm sure you will know that it's because of good interpersonal relationship. So it's possible that you are able to carry out all these tests they are mentioned in your pharmacy shop. You are able to carry them out. You know how to counsel concerning drugs and all that. But there is one thing. Having good interpersonal relationship with your patients, with your customers, is very, very key. Now, I'm going to throw this question back to us. What are some of the things we can do in our pharmacy shop to ensure good interpersonal relationship? I was once a medical rep with GlaxoSmithKline. GSK products, they were not cheap products at all, premium priced. So you cannot tell the doctor, please prescribe my product because it's more cost effective. Or let me use a layman's term, because it's cheaper than other brands. No, always on the high side. But what were we using to sell those products? Good interpersonal relationship. And the doctor will say, I'm prescribing this product because of you. It's not because of your price anyway. Now, I want to ask us, how do we maintain, what are some of the things, let's brainstorm among ourselves, what are some of the things that we do to actually ensure good interpersonal relationship with our patients or with our customers to ensure that they keep coming? So I'm sure quite a number of us, we have community pharmacy practice, we're into community pharmacy practice. So what are some of the things, maybe some of the things that have been working for you, then as colleagues, some of us can learn from you. What are some of the things that we can do to actually differentiate ourselves as well from the quacks that are outside there? Of course, they are all there. They are there, whether we like it or not. And most of the searchlight is always on even registered premises. So I don't want to go into that now. So, we open the floor. Some of the things we need to do, we need to put in place as pharmacists to ensure there is a bond between us and our customers and our patients. Okay, ma. Please, let's listen so that we can learn from each other. How can we increase the customer or the patient turnout in our pharmacy shop? Okay. This mic is failing. Hello? Okay, it has resuscitated again. Okay, please let me give her. She wanted to contribute something. Good afternoon, ma'am.
Good afternoon, distinguished colleagues. I think every area would have, what works in that area. But for me, I've found that my clients, where I'm operating is like a
Please, let's have busy, one class. Let's have one class.
Marketplace. Yes. And people find it difficult to squeeze time to go to the hospital. Okay. So first and foremost, you have to let your clients know that you understand what you are talking about.
We can't hear her. Let's try this one again. The mic keep going.
Yeah. Okay. I said for me, where my pharmacy is like a busy market area. And most clients who come in don't even have time. They want to sit down in their shops and make money. So to tell them to go to the hospital or whatever, they feel reluctant. They feel that the pharmacy is the first port of call for them to come. So the first thing you want to do is to build confidence in your clients. I found clients will come to my place. They have gone to the hospital. They still come back and ask me, this is what I did in the hospital. Do you think it's okay? And that means at least they have confidence. They know that I will tell them the truth. They know that I have listening ears. My clients come in and we are two pharmacists. Sometimes somebody wants to talk to you and they keep going on and on and on. You have to be patient enough to squeeze some time. And then you have to have a feedback mechanism. Like somebody comes in, he's not feeling well, and you tell him to do this and that. Even if you have to refer to a hospital, you tell them, please come back on such and such a day. Let's know what is happening. We take their phone numbers and we follow up. So they know that we are always, that we always have their interest at heart.
Okay.
Then you also have to show empathy. If somebody says something is wrong with them, sometimes they are complaining about money. I've had people tell me, well, man will die of something. And I have a ready response. You must die of something, but you don't have a right to commit suicide. And we talk, and that's, you have to have a cordial relationship with your clients.
Okay. Thank you so much, Ma. You see, having a cordial relationship is very, very important. Because a lot of the time, patients will always come to pharmacy shop before they even go to the hospital. Especially in Nigeria here, it's only when the patient is almost singing, "Oh Lord, I'm coming home." That's when the relatives will rush him or her to the hospital. Now, if I can just summarize what you said, having good time with the patient is very, very important. Because even if they have gone to the hospital, most of the time, because of the workload of the pharmacists in the hospital, they don't have as much time to sit with one patient. Oh, I'll be saying this, I'll be saying that. When they see that you are, you empathize with them. You tell them, take this, take that. And one thing I want to say is that, when you ask them to do something, maybe take this drug at this particular time, we must explain to them the reason why it has to be so. Because some, they don't know. When you say take it before meal, if they take it before me, if I take it after me, what's the difference? They just take it any time, and the drug will not work. And what they will conclude at the end of the day is that, maybe it's fake drugs that they are selling in that pharmacy shop. So it's possible, okay? Is there anyone? Let me just take one more before I make the second point, which is very, very crucial. Yes. What are the things that we can do in our pharmacy shop to ensure that we increase our patient turnover? Because I said, you can be doing all the diagnostic tests in this world. If you don't have that good interpersonal relationship, they may not come. So what are some other things that we can put in place to ensure that, good relationship is maintained between us and our customers? Yes. Do we have? Okay. Yes. At the back there.
Good afternoon, dear colleagues.
Good afternoon.
And thank you, the moderator, for this session.
Okay.
I'm not a community pharmacist. I don't run one. But I do know from feedback that I get from patients and relations and students, I know that honesty and integrity is what keeps that relationship. It's one of the things that keeps that good relationship between pharmacists and their clients. Okay. Because if, for instance, a patient went to a pharmacist and gave a complaint, and the pharmacist gave an honest advice, the patient came with the intention of buying a drug, and the pharmacist told him or her the truth that you don't need a drug. This is what is going on. This one is a side effect of this and that. And the patient goes away, did not spend any money, and got better. They will appreciate that pharmacist and will continue to go there.
Yes.
Especially a patient told me, a relation of mine, she said, you pharmacists, you are a different breed, though. That others would have wanted to make money out of me. But I told her that I have this dry cough. Which cough syrup should I buy? And she said, no. Are you taking any drugs? The woman was hypertensive. I was taking captopril. And told this pharmacist, the pharmacist said, bring the drugs you are taking. And she brought them. She removed that captopril. He said, okay, go home. Don't take it for today and tomorrow. Let's see if you still have the cough. And her problem was sorted without so she sent her to the doctor for a substitute for her hypertension. So she saw that she didn't spend money, but her problem was solved. So there's nothing you can tell her again about that pharmacist and her shop. She keeps going there. And she keeps praising every pharmacist she meets. So I think honesty and integrity is part of it.
All right. Thank you. Thank you so much for that contribution. Thank you so much. You see, like what was said earlier on, was that when you focus on patient care, profit follows. Profit follows. Not only will they come, they will refer other people to your pharmacy shop. So the focus should not just be on, what can I sell now? What can I make now? It should be focused on patient care first, then money follows. Now, there's a question I want to ask us. You know, as a pharmacist in charge of an outlet, it may not be all the time you'll be there throughout the opening hours. Now, I want to ask a question. What are the things you put into place to ensure that your pharmacy assistant don't sell drugs that are meant for prescription only to customers who just walk in without any prescription? I'll give you an example. There was a time I've told my pharmacist assistant, this mic is failing. I told my pharmacy assistant that, of course, the drugs that they cannot sell without prescription. Of course, you know that one of them is Valium. So this particular day, I was in my shop. In my office, small office within the pharmacy shop. So I was overhearing them arguing with a particular customer. And the customer was saying that he wanted to buy 50 tablets of Valium. 50 tablets of Valium. So my pharmacy assistants, they were telling him that we cannot sell Valium to you without doctor's prescription. So I came out of my office. Then I went to the customer. Who was the customer? It was one Aboki, the one we call Aboki now, like that. So I said, what do you want to do with 50 tablets of Valium? He told me that, he said, I sell Agbo. That's this local herb. So what he wanted to do was to pour the 50 tablets of Valium inside. And then, people were buying his local concoction. And then one thing about it is that when people buy that local concoction, they will say, if you buy the agbo from that aboki, you will sleep very well. That he sells very good agbo, you will sleep very well. Not knowing that, what are they taking? Valium. Maybe it's Valium 10 or 20. Now, you see, anytime I have the opportunity of talking to maybe an audience that is not medical, I always tell them, for those of you who are fond of taking this agbo, the one they sell by the roadside, I said, for the little will you know that some of you are shacking Igbo every day. You are shacking Igbo every day. Some of you are taking high doses of tramadol every day. Some of you are taking high doses of, especially the one they call, I don't want to mention the brand, Okpai, Sinadefil, Fanadefil, Tadalafil. Those are the ones we are taking now. You don't know. So, another thing we should do, please, when we are counseling our patients, when they come to pharmacy shop, let's ask them, are you taking any local herbs? Where did you buy it from? Some of them are taking excessive doses of prescription drugs or opiums. I want to say, may God help us in Jesus' name. God will help us. I think we need the help of God in this practice. Thank you so much. Thank you very much.
Can we just clap her? Okay, let's give a round of applause. I really want to appreciate her for that last part of it. Less than 6 months after I started my practice in community, the patent medicine dealers in that area actually paid me a visit, and they wanted me to be a source of buying such drugs. And what I found out was that they will buy anti-malaria, put it inside the agbo for malaria. Buy chloramphenicol, put it inside agbo for typhoid. Like you said, ma, they will buy that and put. So when you are taking those agbos, it's working for you accordingly. So may God save Nigeria. We are now on the last part of the masterclass, and we have Pfizer in our midst. Can we give Pfizer a round of applause? Pfizer. I have Osakpon. Am I right? Oh, clap for me. Everybody clap me. Nobody's clapping me. Osakpon Frank Odige as the health representative of Pfizer. Let's give him a round of applause as he takes the microphone. You have 1 hour.
Thank you very, very much. Yes, I'm sure you can. Good afternoon, everyone. I take this privilege as no small one being in your midst this afternoon. All protocols duly observed. My name is Osakwawan Frank Odige, and I am a pharmacist, a proud one. Thank you very much. A proud one because one way or another, the contributions of each and every of our seniors and our elders in the profession have trickled down to what I eventually earned and benefited from in school. A proud one because every time I have to represent myself or represent my organization as a pharmacist, in the midst of pharmacists, I see that where we are heading is a brighter future, owing to the sacrifices of everyone in the house this afternoon. So this afternoon, I am actually going to be presenting on anticoagulation in stroke and systemic embolism. In NVAF is a short form of saying non-valvular atrial fibrillation in NVAF patients, as well as in prevention and treatment of DVT and PE, what you put together and call venous thromboembolism, VTE. But then the first question we'll have to look at is, why would a pharmacist need to know all of this? Why would they need to concentrate on anticoagulation? Why is it important that we start looking at the importance of anticoagulation? And more importantly, what is a pharmacist need? What is the need for a pharmacist in this particular area of clinical practice? It's clear that an hematologist will find a very important practice area here. It's clear that a cardiologist will find it important in his practice. But a pharmacist's contribution is also important as well. So we'll be looking at it through the mirror of this outline. We'll look at the unmet need of anticoagulation. My mic's still working. We'll look at the unmet needs for anticoagulation in stroke prevention and VTE management. We'll also look at a CHADVAS score, which is something you will really find interesting. We'll look at the indication and benefits of Pfizer's innovative solution in anticoagulation. We'll also look at the pharmacokinetic and studies that backs up its use. Of course, importantly so, we'll look at the precaution and contraindication of our products. And again, as a bonus, we'll also get to see antimicrobial resistance, stewardship, and the relationship with vaccination. With your permission, I would like to continue. So this is He said the risk of stroke is up to 5 times higher in patients with atrial fibrillation. Allow me to describe what atrial fibrillation is. It may sound like a medical jargon that you need a lot of explanation around, but think of a hose or think of a pipe carrying water. And think of a hose or a pipe carrying water to a source or towards a pump, or more like a sub pump that takes water to the top floors in a building and other parts of the building. Now, if that hose does not pump water consistently at a particular flow rate, if it doesn't flow consistently, what you may find is in the case of blood, it carries not just water, it carries nutrients and so many other things. You will now find that the way what it's sending to the different parts of the body is not consistent. So sometimes it may send more hemoglobin, sometimes it may send less. So you will now find either backup or build-up of sediments that can eventually lead to blockade of that particular artery, or in this case, we are describing it with a pipe. You also now find that those sediments, when the flow rate eventually increases at other points, because the heart is not functioning as it should be, and when the flow rate increases or changes, it could also dislodge this sediment it has formed and send it to areas of the body where it can cause severe damages. So in this case, when those sediments caused by improper flow rate or inconsistent flow rate, when they get dislodged, they may find themselves in the brain, leading to stroke. I don't know if that makes sense. So we'll find that if the heart is not pumping consistently to give consistent flow of blood, sediments will form, and these sediments, when they are dislodged, when there's a higher flow rate, you will find them dislodging to cause stroke. The same way, it could also lead to something that's related to the topic. We'll talk about VTE as well. In the same way, when there's a problem and sometimes there may not be a problem with the pump, which is the heart. There may be a problem with the consistency and the nature of the blood itself. Maybe because of one blood infection. It could also be because of the nature of the pipe. Maybe the pipe is already getting old. You find this particular artery in a 60-year-old and a 75-year-old. It could also be because of one underlying condition or even a medication. You find that this pipe is narrower, and dislodging plaques inside this pipe can eventually lead to a blood vessel getting blocked along the way to the heart, this time not in the brain, leading to a deep vein thrombosis, something you will commonly find as maybe a swollen leg or a problem. Think of those patients who will need to wear compression socks. Think of those patients who need to use some of the anticoagulants we know. Think of those patients who have had orthopedic surgery or one surgery or the other, and they have to remain on the bed for a period of time, roughly around 2 to 3 days. So if a patient should remain immobile for a period of time, of course, the consistency and the nature of flow of the blood it's not the way it should be. So you can have those sediments build up, and when they are dislodged, they will eventually lead to either DVT, or in the case when the heart is not pumping blood properly, we now think of this risk of stroke, since it can send these sediments to the brain, causing stroke. Now, as we've established, the risk of stroke is up to 5 times higher in patients with atrial fibrillation. Remember that pump that's not pumping consistently. That is in atrial fibrillation. Now, there's a particular type of atrial fibrillation. We call it non-valvular atrial fibrillation. Non-valvular may appear like big grammar, but non-valvular simply refers to non-valvular simply refers to moderate to severe mitral stenosis. It means that the mitral valves are very much okay, and it means that in the case of non-valvular, it means that the mitral valves are very much okay. It also means that there is an absence of a mechanical heart valve. Quite a few patients may have mechanical heart valves in Nigeria, but in some parts of the world, it's something that is common among patients whose hearts may not give them the consistency or the consistent rate of flow as it may be. It's becoming more and more common with high-end surgeries happening in Lagos more and more by the day. So non-valvular means that you will not find mitral stenosis. The mitral valves are fine. It also means that there's no mechanical heart valve. In the case where these exist, they will need to use our good, old, and trustworthy warfarin. However, there's an issue with warfarin that we all know. I like to put, each time I'm in Lagos, I like to describe it this way, that an issue with warfarin is ewedu, an issue with warfarin is our vegetable soup. Because every time we have to abstain, we have to use warfarin, you may not be able to enjoy these meals because there's a high level of vitamin K in these meals, right? So it means that a patient using vitamin K cannot enjoy the full extent of the life that they want to enjoy. Baba has grown up knowing that ewedu is his primary meal. If he wants to enjoy life, he goes for ewedu. And now you are telling him there's a medication he's using, he can no longer use ewedu. Are we still talking about quality of life? Please follow me. So, importantly, we also look at one of the important steps where pharmacists and pharmaceutical caregivers can find important place to practice. This particular score is called the Chadva score. Very common among hematologists and cardiologists. There's another one also, although not present in my slide. They call it the Hasbled score. Now, the Chadva scoring was invented by the European Society of Cardiology, and it sits at the very bedrock of determining if a patient will require anticoagulation. Remember that pump not pumping very well? It will be safer to make sure the blood is thinner, and it will be safer to make sure the blood is thinner, so that whether the pump is working well or not, it can easily move the materials and nutrients from one part of the body to another part of the body. Established? Right. Okay, so the Chadva score looks at these important points. You find congestive heart failure. We find hypertension as a factor there. We also find age being a factor. If it's greater than 75, this person has 2 points on the Chadva score. We also find diabetes mellitus. Sounds common in elderly patients, right? We also find prior stroke. Has this patient had a stroke before? Or TIA, or transient ischemic attack, that's TIA. Or has this patient ever had to deal with a thromboembolic event before, where they threw up a clot, or there's an established blood vessel somewhere that is blocked? Has this patient come down with any of the vascular disease before, myocardial infarction, peripheral artery disease, or even a plaque in any of the arteries? Is this patient age 65 to 74? Remember that from 75 and above, they have more points. They are more at risk. Is this patient also a man or a woman? It also comes to play there. Now, the Chadva scoring will tell you that when this patient has 0 points, of course, there's a low risk of stroke. Then, of course, there may not be a need to use an anticoagulant. Remember, the pump not pumping very well, and the thinner the blood, the easier it will be for this pump to perform its function. Now, by the time it's intermediate, you find that you may consider it in men, but in women, it may not be required. However, being a woman gives you 1 point already. So does that even things out now? It kind of does. Now, for high stroke risk, you agree that from 2 points and above, having 1 or 2 of these risk factors we cited earlier will put this patient as one of those patients you want to recommend to the doctor, to the physician, or have a discussion to go back with this patient to go back to the doctor to get an anticoagulant as part of his drug regimen. However, from 3 and above, it is recommended. Now, when we look at this, it may appear like something that maybe you may need to draw out a lot of things to be able to apply it, but it's not exactly like that. I'll show you something in the next slide. A very typical patient you will find. So, a 76-year-old male, we can work on this together. Please follow me. So, a 76-year-old female comes in regularly to refill metformin and amlodipine. Are these bestsellers? Okay. So, it's common. If you go to a pharmacy and you don't find metformin and amlodipine, you just reduce the license, call it a patent medicine store, right? Okay. So, comes in to refill. So mama comes in to refill her metformin and amlodipine. And these are the medications. Now, this patient shows up with a new prescription for amlodipine and Vasartan 10-160, owing to the fact that the doctor now finds that there's a risk that the heart is pumping blood inconsistently. Remember atrial fibrillation. It sounds very common and regular, right? Now, the question is, what other recommendations, based on the Chadva scoring that we've looked at, do you have for these patients? Would you have for these patients? Anybody, please. Anybody? Okay. That wants to say something.
Anticoagulant to this one. Yeah.
So far, I'm saying that it's important to add an anticoagulant to this patient's treatment. Now, do we add it ourselves, or we send the patient back to the prescribing physician? Okay, that's debatable. But what is important here is that this patient respects you a lot more now. What's important is that pharmaceutical care services has been rendered to these patients. And another thing that is also important is that this patient will trust you with his drug decisions and drug-making decisions every time they come to your practice setting. Does that not sound like an important thing to retain a customer? We talked about how to interact with our customers earlier on, and I enjoyed the conversation. These are some of those ways we make sure we offer valuable services that will bring this patient again and again to our places. Now, for this very patient, if we go back to the Chadva score, we find that in the 76-year-old mama, she already has 2 points, right? She has hypertension, that's 3 points, right? She also has diabetes, that's 4 points. It is important that this patient already starts on an anticoagulant. So moving on, Pfizer looked in as a champion in bringing innovative medicines. We strive to make sure we are changing patients' lives with our medications. So Pfizer is introducing Eliquis. It has gained much ground in the market. Eliquis comes at 5 milligram or 2.5. This is exactly how you will find Eliquis available in the market. Eliquis is apixaban. Now, what is apixaban? It is a direct factor 10A inhibitor, and it acts on it's not showing. It acts on factor 10A, and as you can see from between the bridge between the intrinsic and the extrinsic pathway, factor 10A sits right at the middle. So an anticoagulant that acts on factor 10A will effectively be able to block your intrinsic and your extrinsic pathway, since it meets at the very bridge of the intrinsic and your extrinsic pathway. Now, what's also important to take note of here is that at the junction of both the intrinsic and extrinsic pathway and of the anticoagulants cascade, Eliquis acts on that particular place. And that site, factor 10 is a site of optimum amplification in the anticoagulation cascade. Because it is a point where both the extrinsic and the intrinsic pathway meet. Now, it has no known rebound effect on cessation when therapy stops. For example, we think of a patient that may not have non-valvular atrial fibrillation we described earlier, but he has deep vein thrombosis, or put them all together, call it VTE, venous thromboembolic disorder. He only needs to use an anticoagulant for a year or thereabouts, not consistently, unlike when you have non-valvular atrial fibrillation. These patients may need to stop at one point. Or perhaps what you even find is sometimes finance may make the patient become inconsistent at some point. Because it is a factor 10 inhibitor, you do not find a rebound of the condition you are trying to treat. So it holds no tendency for being counterproductive in these patients. Now, for Eliquis, the indications are 6. To reduce the risk of stroke and systemic embolism in non-valvular atrial fibrillation we talked about. For the treatment of deep vein thrombosis, it also is indicated in treatment of pulmonary embolism, which is when a clot travels to the it travels to the lungs or any one of these tiny blood vessels that exchanges blood from between the lungs and the systemic circulation. Now, it also finds use to reduce the risk of recurrent DVT and PE following initial therapy. Now, in this very part, Eliquis has actually taken the market. I've had a professor of cardiology tell me that Eliquis is the elder brother to the other oral anticoagulants. And his assertion was simply based on when he finds a patient that's not doing so well in any of the other oral anticoagulants, he simply tells his other consultants or residents to take the patient up to Eliquis. So that was his own reason why he said Eliquis is the elder brother to the others. Now, it's also indicated for the prophylaxis of DVT that could lead to pulmonary embolism in patients who are undergoing elective hip replacement surgeries. It's also indicated in preventing DVT and pulmonary embolism in patients who are undergoing knee replacement surgeries. Now, let's look at the clinical pharmacology. This is where of Eliquis, apixaban, that's the product name. Comparing it to warfarin. Mechanism of action, warfarin will act on vitamin K epoxide, effectively inhibiting factor 2, factor 6, factor 7, factor 9, and factor 10. However, Eliquis is a direct factor 10A inhibitor. In this same mechanism of warfarin, that's where you find some of the most common contraindications for warfarin, where you find it interacting with the daily life of the patient, not allowing them to do other medications or other food that they may very well enjoy. Remember we talked about Ogudu. Remember we talked about vegetable soup. These are common in our everyday meal. Hence, it is a challenge when a patient has to go on them, since it directly impacts on their quality of life and on the quality of life and on what they usually would enjoy. Now, for Eliquis, it is 50% bioavailable. This in itself speaks to the safety of the medication. Now, it speaks to safety simply because for a medication that has a tendency to make the blood thinner, if it is fully bioavailable, it means that a scratch to the body could lead to bleeding, uncontrolled bleeding. For food effect, you do not have a food effect with Eliquis. However, with warfarin, you have a food effect. Remember we talked earlier about when there is no mechanical heart valve. When there is a mechanical heart valve, you have to switch to good old warfarin. What it means is that warfarin is still very much effective. It works very well. However, because of these side effects and contraindications, which you may not be able to fully control, there is a need to use any of the novel oral anticoagulants. They call them NOACs, which Eliquis sits top of the chain. Renal clearance, you do not find much renal challenges with Eliquis. Remember, we talked about Agbo earlier before this presentation, how you find a lot of kidney challenges springing up here and there because we may not know the full extent of the herbal concoctions people are taking or that they've used in time past. We may not know the full extent of the health choices that people are making today. However, Eliquis sits on the safest point when it comes to renal effect. It's only 27% renally cleared, the least of all known anticoagulants today. However, you find your warfarin predominantly cleared by the renal system. What is the half-life of Eliquis? Effectively 12 hours. Where this is a very big benefit, particularly to the doctors and the pharmacists in the hospital, is that if a patient has to go back for a revision surgery, sometimes the patient is wheeled out of the theater, and in 12 hours they think of quickly going back to correct something to save a patient's life. If this patient is on Eliquis, in 12 hours you can be sure that the patient is getting to safety. However, with some other oral anticoagulants, you may not be able to guarantee that. So Eliquis sits on safety. Coupled with its half-life of being 50% bioavailable, it sits on the sweet spot between safety and efficacy. Balance, right? Now, we also find that the drug interactions are numerous when it comes to good old warfarin. But for Eliquis, you do not find so much drug interaction. Hence, it speaks to the safety and flexibility, the safety of Eliquis as well. Moving on to the clinical pharmacology, comparing how does Eliquis compare with other known oral anticoagulants, or as they call them, DOACs or NOACs, directly acting oral anticoagulants or novel oral anticoagulants. Is Eliquis a prodrug? No, it is not. Is dabigatran a prodrug? Yes, it is. One of the challenges with having a drug as a... Oh, I thought I had an hour. I was told I had an hour. Okay. Is Eliquis a prodrug? No, it is not. Is dabigatran a prodrug? Yes, it is. One of the challenges with using a drug that is a prodrug is you may not know how the body processes the initial ingredients to give you the drug itself. So you may not... So for some patients, idiosyncrasies may come in. A patient may release more of the real active ingredients, while another patient may not release as much of it. That's a challenge, right? But Eliquis does not give that challenge. Is there a food effect? No. Eliquis can effectively be taken on an empty stomach. Speaks again for safety. I wish we were counting the points so we know what points we are seeing as an advantage in Eliquis. Renal clearance, I mentioned earlier that it has the least known renal clearance when it comes to oral anticoagulants. No other anticoagulant comes close to Eliquis because it's 27% renally cleared. No anticoagulant is dialyzable. Again, you see that in 2 to 3 hours, Eliquis is already available in the patient's bloodstream. This speaks to how fast and how early you can initiate Eliquis in a patient, maybe post-surgery or when you need the effect to quickly kick in. However, remember for warfarin, you need to wait 2 or 3 days before you start seeing the effects in the patient. And then you start thinking of where to find a balance for that very patient. For Eliquis, in 2 to 3 hours, your patient is good to go. Hence, it does not need to be bridged with lower molecular weight heparin. We also look at, remember I mentioned that Eliquis is 27% renally cleared. It has multiple routes of excretion. So a more common challenge that patients will have is renal clearance or their renal system being challenged by surgery. If you cut through a muscle, you send waste products to the renal system to clear. So post-surgery, the safest oral anticoagulant will still remain Eliquis because there's a lot of metabolic waste that your renal system will have to deal with post-surgery in a patient. Hence, you need a safe oral anticoagulant that does not bring a challenge to the renal system like Eliquis. You also find in one of the major studies that compares Eliquis with enoxaparin, you find that Eliquis compared to with warfarin rather, in stroke and systemic embolism, Eliquis has a 21% risk reduction rate. 21% risk reduction rate, speaking for efficacy, more efficacious than warfarin. However, when it comes to safety, you find an even greater risk reduction rate when it comes to major bleeding, which is a major concern when you are instituting an oral anticoagulant or when it is being needed in patients. Then you also look at all-cause mortality. Now, this study did not just go out to look at whether the patient died because of an anticoagulant or something. He looked at whether any of these patients enrolled in this study passed away. Eliquis also had an 11% reduction in any cause of death in these patients. Is that not an advantage? It is. This is also what we looked at again in this particular study, the Aristotle trial. You see Eliquis giving a far greater superiority to warfarin when it compared for stroke and systemic embolism reduction, which is a major factor you look at in patients who have non-valvular atrial fibrillation. Again, another study, which is the Yao study, compares not just Eliquis, but all the ones available in this country today. Rivaroxaban, apixaban, warfarin, in this particular group of patients that will require anticoagulation to make sure their blood flows better and do not leave sediments. The Yao study. The Yao study results, I wish I could zoom in a little. If you would find a major source of bleeding in these patients is gastrointestinal bleeding. Sometimes mama also has other conditions that would require her to might have used NSAIDs before, or she might have had peptic ulcer or some other challenges. Gastrointestinal bleeding is a major challenge because if the patient bleeds inside the GI, you will not know until there's a real problem. So it is a major concern among doctors, and you would have done this doctor a great deal of good by recommending Eliquis, because when you find gastrointestinal bleeding on the other side, please, on the other side, you can screw to the other side. No, to the right. Okay. In gastrointestinal bleeding, you find Eliquis as the only oral anticoagulant that gives benefit compared to warfarin, compared to dabigatran, compared to rivaroxaban, and also compared to warfarin as well. You find Eliquis as the only oral anticoagulant that gave clear advantage when it comes to major bleeding, intracranial bleeding, or gastrointestinal bleeding. I would like to also extend that it will also give benefits in any other form of bleeding. These are the major ones also looked at. When you also compare, when it comes to safety, you find that stroke on systemic embolism, which is the major reason why they will need to use Eliquis. Eliquis also gave a very clear advantage on the other side compared to any other NOAC available today.
Just a minute.
Okay.
Please, the owner of this car should kindly repark. Someone is about leaving. APP 458JF.
Thank you very much. That's actually my car. Okay, if somebody can help me. Okay. So my colleague behind will help me. She's behind. Okay. Thank you very much. So another study we should also look at, this time around, we are looking at prevention of deep vein thrombosis in patients who would have undergone hip or knee replacement surgeries. Now, why were this particular set of patients picked? It is simply because these particular surgeries would require a lot of manual maneuvers, orthopedic surgeries. Somebody called orthopedic surgeons that they are the carpenters of the medical world because they have to do a lot of maneuvers that will involve a blood vessel cutting open, breaking open, and also even sometimes they have to even drill open in some areas. Now, this particular set of patients that had to undergo hip and knee replacement surgeries, we also looked at in a study representing a larger pool of patients who would have to undergo just any surgery you think of that are at risk of deep vein thrombosis. Now, the Advanced 2 trial looked at patients who would have undergone these particular surgeries. And again, you find that Eliquis gave a major 50% risk reduction when it came to major bleeding compared to enoxaparin, which is something you would use every other day. Another comparison with enoxaparin that speaks to us every other day is in terms of cost. A day's dose of enoxaparin for the average patient in the hospital will cost not less than 8,500 naira. However, a day's dose of Eliquis twice a day, morning and evening, will not cost the patient more than 1,350. And in a week, they would not spend more than 8,500 naira. So what you find as a day's dose of enoxaparin is actually what you find as a week's dose of Eliquis. But then, from this particular study, you see the superior sign there. It was 38% more superior to enoxaparin in this particular study. Coupled with the fact that you can start it, you don't have to bridge with enoxaparin. With dabigatran, you have to bridge. You have to start with enoxaparin for a while, then move on to oral anticoagulant. With Eliquis, you can start directly. You do not have to bridge. Does that go a long way in saving costs for our patients? Of course it does. Another study also compares it to enoxaparin. You see that in the outcomes of major bleeding, the advantages are enormous. Again, just to point it out, Eliquis is simple to initiate and switch. Remember those patients whose hearts are not pumping very well and they will need oral anticoagulants. They will require 5 milligrams twice a day. However, if they meet a particular criteria, we call it the ABC criteria. The ABC criteria stands for age above 80 years of age, body weight below 60 kg, as well as the serum creatinine greater than 1.5 milligram per dl, or what you call 133 micromole per liter. If they meet two out of these three criteria, they will need to do a 50% dose reduction. So this is where pharmaceutical care also comes in very well. The fact that you can easily guide and tell these doctors how to make this adjustment. Or a patient shows up in your clinic, friendly, lives in the neighborhood, and you have to counsel them on how to adjust their dosing to meet what their blood works is saying, or the age or body weight. Again, remember those other patients we mentioned that have undergone surgery, remained in the bed for greater than 3 days, that are at risk of deep vein thrombosis, or perhaps they're already treating it. These patients, if they are treating, they will need 10 milligram twice a day for the first 7 days, 5 milligram twice a day for the next 3 to 6 months, depending on the clinical discretion of the doctor. Then a maintenance dose of 2.5 milligram twice a day to maintain that patient on steady anticoagulation. However, if it's a patient that's just on the bed, or there's a patient that you are preventing from having DVT, they will only need 2.5 milligram twice a day. An advantage it also has compared to other NOACs in the market is costs. Typically, people will assume it will be more expensive because it has more benefits and the data shows that it is more efficacious. But then, as we speak today, a pack of Eliquis that will last a patient for a month will not cost a patient more than 45,000 naira from Pfizer. So add markup, add whatever it is, it still sits around 50, 55, thereabout. But on the average, I am aware that for rivaroxaban, branded rivaroxaban, you would not find, I'm not talking about parallel imports. I know we don't do parallel imports here. Even for parallel imports, you can still compare. When, for branded rivaroxaban, you will need at least 65 to 70,000 for a month's dose. So at Pfizer, we looked at the fact that patients will need all the support they can get, particularly at this time in our nationhood. So Eliquis will not cost your patient more than that in a month. So compared to, with all the benefits we've listed out before now, Eliquis still sits at a very, very competitive price that will not bore a hole in your patient's pockets. We know that these patients will need other medications. They would have been on other medications, and that is why that pricing is optimal, and it is important that we also emphasize that to our doctors, to our patients. A patient could walk into your pharmacy, they use rivaroxaban, and they complain about cost. You can ask them to talk to their doctors about Eliquis so they can benefit from both reduced price and better efficacy outcome. Remember all the other studies we looked at that points to Eliquis being the most effective oral anticoagulant in the market. Again, another advantage of Eliquis is that what if a patient forgets to take Eliquis in the morning and he gets to say 10 a.m. in the morning, 11 a.m. in the morning? Should he still go ahead and use Eliquis? Yes. He can use Eliquis and still maintain the evening dose of Eliquis without having a challenge, since it's used twice a day. Again, comparing Eliquis with other available oral anticoagulants. When it comes to renal clearance, Eliquis still stands very strong as the least renally cleared. So for renal safety, think Eliquis. Again, when you look at the age adjustment for the patient, you will need to adjust dabigatran every time a patient's weight crosses a particular threshold. But for Eliquis, you would not have to. Another advantage is that for Eliquis compared to rivaroxaban, renal clearance adjustment, I tell doctors this: if you put a patient on Eliquis, you can go to sleep and be sure that your medical officer that joined you yesterday can handle the patient, because you don't have to think about so much dosage adjustments when it comes to age, body weight, because it's just a one size fits all in Eliquis. Another advantage when you look at Eliquis again is that you do not have to administer with food. It's safe enough to go on an empty stomach. Okay, I'll skip this. How do you switch patients from rivaroxaban, from dabigatran, from from enoxaparin and other oral anticoagulants, or even injectable anticoagulants to Eliquis? Is actually that simple. If the patient is using warfarin, just wait until the INR is less than 2, and you simply switch the patient at the next available dosing. That simple. If the patient is using other NOACs, simply discontinue and start Eliquis as the next available dosing. It is that direct. If this patient is using a low molecular weight heparin, like your enoxaparin and the likes, you discontinue and you start Eliquis at the next available dosing. Remember that medical officer we talked about who just started work yesterday? He can use Eliquis without being so bothered about making a mistake in drug therapy. Does that support our practice? Yes, because it means there's less drug therapy problem to handle on our end, allowing us more time to make sure that other medications are available for the patients. Again, when the doctor comes walking up to you to ask, when can I start using Eliquis in this patient who just had surgery? If the surgery is going to be, who needs surgery, if this surgery is going to be high risk of bleeding, you will need to discontinue Eliquis 48 hours prior to these surgeries. However, as these surgeries have low risk of bleeding, an example of low risk of bleeding surgery may be using an endoscopy tube and others. They can discontinue Eliquis 24 hours before, and that speaks to safety. With some other oral anticoagulants, you will need to discontinue way much more further. Does that speak to safety with our patients? Yes. And again, Eliquis, just to cap it all up, Eliquis is a single oral anticoagulant that can be prescribed from start. Remember I mentioned that we do not have to bridge Eliquis with other low molecular weight heparins like your enoxaparin before. The patient can simply start with Eliquis and finish with Eliquis. It is that simple for Eliquis. And with the simple dosing regimen, it means a medical officer that started yesterday or a pharmacist that just resumed the internship yesterday can guide the physician on how to use Eliquis without having challenges. Now, patients with Eliquis do not require initial bleeding and bridging with any other low molecular weight heparin. It saves both costs, like we mentioned, and it also saves having to do a lot of calculations and thereabouts. Remember your age, body weight, and your creatinine clearance. Eliquis also sits in the very center of the balance between safety and efficacy in this group of patients. Now, our ask these days that when next we are asked to recommend any oral anticoagulant for our doctors and our patients who are so dear to us, we should start with Eliquis, and we should also dispense these reasons that we've discussed so far as a very important reason why there should be on Eliquis as a safe and effective oral anticoagulant in their practice. So these are some precautions we should also look at. It's also it goes without saying that with aspirin, other NSAIDs, and clopidogrel, the risk of bleeding can also be more. Hence, there's a need to use with caution, or use with caution, or completely discontinue these ones if you can. Again, we also look at other medications that affect your enzymes, like your amiodarone, diltiazem, naproxen, and verapamil. It's important that we have all of this at the back of our hands to guide our physicians on how to use them very well. Or a patient could come in treating a fungal infection, and he also needs Eliquis. You can easily guide these patients on using them because they also induce these enzymes as well. Eliquis is contraindicated in patients who are hypersensitive, and also in patients who have conditions that predispose them to major bleeding. It's also contraindicated in this patient. It's contraindicated in this patient. Now, the question this afternoon is: would you recommend Eliquis to a doctor or to that patient who is complaining about cost in their patients? Thank you very much. That's very good. Another question I want to ask is: would you recommend Eliquis to a patient who has renal challenges but needs to be on an oral anticoagulant regardless? Thank you very much. Would you recommend Eliquis when safety and efficacy is of topmost priority? Thank you very, very much. This is okay. I'll stop Eliquis here. Just as I mentioned that we also look at, as antimicrobial stewards, I will be doing a great deal of disservice if I do not also quickly touch on something that is of immense benefit to our practice, especially those of us practicing in the city of Lagos. We find a lot of patients who come up to us with either pneumonia, a chest infection, or some other conditions. Adult patients and children alike. Sometimes it may bring us more revenue to give them antibiotic But in the long run, it will bring us more respect, more value, and ultimately a client, a customer that will always return back to us if we recommend vaccination to these patients. Vaccination can mean the difference between life and death, and I'll show you why. Think of these patients who have lung disease, patients who have cardiovascular disease, patients who are diabetic, patients who are immunocompromised, or even patients who smoke. And all these patients will not come to you and tell you, I smoke, I have diabetes, I am immunocompromised. You will see it in the medications they are coming to buy, right? You will see it in a patient, a cardiovascular patient who have cardiovascular disease coming for his antihypertensive, coming for other medications, amiodarone and the likes. Now, these patients being able to walk up to you in your practice means that they are stable. A major challenge, something that can challenge the stability of that patient, is a chest infection. I think of Mama who has been dealing with heart failure for a while, and now she's stable and she's okay, only to come down with a chest infection. That may not just send her back to the hospital. It may send her beyond the hospital. So if you recommend vaccination against pneumococcal disease, Prevnar 13, it does a great deal to help that patient. The testimonies abound. I've had a doctor in Benin tell me that since he used Prevnar 13 on this patient, on a 68-year-old woman who used to come down with continuous chest infection. Every now and then she comes to the hospital every 3-6 months for one chest infection or another, pneumonia actually. He has not seen this patient come back to the hospital for that same infection. So it's important that when these patients come, and again, if we also look at it, we might not have given this patient antibiotics, but we've also done this patient a great deal of good, and we've also brought in revenue to the business by recommending vaccination. In fact, with pharmacy-based vaccination on the rise, you would also earn from the services of vaccinating these patients. I cannot think of any antibiotic that will sum up to the amount of any antibiotic today that will sum up to the amount of vaccination, the vaccination service, as well as the product you are vaccinating with. Does that sound like a good deal for our pharmacy outlets? It is, right? So then, how do we identify these patients who will need vaccination beyond the medications they will need? It's important that we also know the HALO approach. The HALO approach is health conditions, age, lifestyle, and occupation. Think of that smoker or that person who works in construction. Think of that person who has to deal with a lot of asbestos. Is at risk of pneumococcal disease and should be vaccinated. Think of that healthcare practitioner. Think of that pharmacist. Is at risk of pneumococcal disease and should get a shot of Prevnar 13 vaccine. How do you use it? One shot for life. You do not need to update. You do not need to recommence, or you don't need to use it after 5 or 10 years. It's one shot for life. And that completely protects the patient. Think of the health conditions as those conditions we looked at before now. And also think of the lifestyle of these patients. These are things that you look at, and you quickly identify a patient who needs Prevnar 13 vaccine, as well as any other vaccine you would think of. The HALO approach has come to simplify things. Thank you very much for listening to this presentation. I will take questions, recommendations, or contributions from now. Thank you, and God bless you. Please.
Yeah, please, thank you very much for that wonderful presentation. I want to know what that INR means. Okay. Then, two, in the case of the woman that we studied, her age, diabetes, and hypertension, where we are supposed to use apixaban. Then, supposing you use clopidogrel there, or aspirin, 75 milligram, what would be the difference?
Sorry, I missed you for a while. If you can take the second question again.
Okay, Equilis, good for the woman, under discussion, review.
Yes.
Now, in place of Equilis, supposing you place her also on clopidogrel or aspirin 75 milligram, okay, what will be the result? Then 2, what's the full meaning of that INR?
Okay, thank you very much. So INR stands for International Normalized Ratio, and it's...
Colleagues, the food are more than enough. So please, let's just when it's your turn, the social secretary will call you. So, but we don't want this place to be empty. So that's why we are doing it orderly. So let's just sit down and enjoy our lectures. But our food, whatever you want, just ask when you get there. Thank you very much.
Thank you very much. So INR stands for International Normalized Ratio. It is a test that a patient will have to do every other time. And I would like to add also that it is a hidden cost of using cheap. It is one of the hidden costs of using the medication called warfarin, because every time the patient has to come to the hospital, they will have to monitor or do an INRO test, which costs around 7,000, 8,000 every time they have to come to the hospital. So think of getting warfarin for maybe less than 1,000 naira for a month, maybe, and you have to do INRO test every 3 weeks. You have to come to the hospital. That kind of brings it about the same price with Eliquis, right? Just also correct that it's Eliquis, not Equalis. Thank you. Now to the second question, and the patient we looked at, he said if this patient would not require clopidogrel, aspirin, and all, it is actually not indicated in patients who require anticoagulants are the mainstay. According to the American Society of Cardiology, anticoagulants are the mainstay of treatment in patients who have non-valvular atrial fibrillation. Remember that pump that's not pumping well and leaving sediments as it goes, and these sediments can travel to the brain leading to stroke. It's an anticoagulant that is recommended. So in time past, people would use aspirin, people would use clopidogrel, but those are no longer recommended in this group of patients. In fact, what is directly recommended is a direct-acting oral anticoagulant like Eliquis. You either call it DOAC, direct oral anticoagulant, or NOAC, novel oral anticoagulant. They are actually the mainstay, and they are the recommendations that are current in managing these patients. I don't know. Does that answer your question, sir? Okay. Further questions, please. I'm expecting a question from maybe the vaccine we looked at. Prevnar 13 against pneumococcal disease. Okay, for the vaccine, thank you very much. The vaccine will cost your patient around 30,000 naira for a shot. But the benefit is that it's a single shot for life. So think of elderly people. Prevnar 13 against pneumococcal disease. Simply put, a chest infection that can complicate any other condition that this older person is having to deal with. Okay, thank you very much. So there's a question behind. Oh, thank you very much.
Concerning the vaccine,
are
there possibilities of complications or adverse drug reaction after taking the vaccine?
Okay, so with any medication, apart from the everly renewed Buboniche that does not have any side effect or challenges, you will always find, in fact, a very common challenge that you find with just any vaccine that is injectable is injection site reaction. So for some vaccines it is more, but with Prevnar 13 it is no more than what is ordinary, and it is not something that the patient cannot deal with. In fact, a child of 4 weeks old can use Prevnar 13, the same Prevnar 13 that an adult and an elderly person should use. So that should also speak on its safety and the mildness of this vaccine in these patients. So it is very safe. Mama has a question as well. Okay, Prevnar 13 contains pneumococcal conjugate vaccine. It contains 13 serotypes. In fact, I'll further break it down to say, in children who receive what the government offers PCV, pneumococcal conjugate vaccine, with 10 serotypes. As you know, herd immunity will come in at some point. A lot of adults here would have even gotten 10 serotypes when they were younger. as children as part of the routine immunization. So it means that when those 10 serotypes that you've been vaccinated against come, you are protected, right? With Prevnar 13, but then you still have people who come down with pneumonia, chest infections that are being caused by strep pneumonia, right? So what then will be the major reason for it? It means those serotypes that we are not vaccinated against will actually form the primary basis for infection, new infections, because there's herd immunity already with 10 serotypes. So Pfizer's 3 additional serotypes, 6A, 3A, and 21, now forms a much more stronger reason. It now gives you a much more stronger reason why newer patients that should be vaccinated, children and adults and elderly, should get PCV13. In fact, PCV10 is not even indicated in children. It's indicated, but PCV13 is indicated in children from 4 weeks to even the elderly. So I don't know if I've broken it down. Currently in Nigeria, it is PCV13 that's the broadest that we have, and that is from Pfizer. And it covers against 13 serotypes. 3 of those serotypes form the mainstay of current and new infection, owing to herd immunity to the previous 10 serotypes we've been using. Does that communicate it well? From 4 weeks to the very elderly can use Prevnar 13. Any other question? Okay. The absence of none, I would like to stand on existing protocol and say thank you very much for giving me your ears. God bless you.
I think it deserves a very, if you're not eating, and if you're eating, please just, it deserves a very, very good round of applause. When I see young ones present in this manner, I am impressed. The profession has a good future. Thank you very much. Please, if you have not had your photo shoot, you can take your...
Good afternoon, distinguished pharmacists. My name is Joy de Malaria. I represent NewHeights Pharmaceutical. So we have 3 portfolio of our products. The first on the list is the health check ranges. So here we have the pregnancy test kits that detect pregnancy as early as 4 days after conception. It is a product of choice when you want to detect HCG. Then we also have the PSA test kits that detect prostate-specific antigen. We also have the Triple H viral cassette. It's the first cassette here in Nigeria that detects HIV, hepatitis B and C at the same time with one sample, with a single blood sample, without cross interaction. And then we also have the H. pylori cassette. We have also our BG check machine, a blood glucose meter, and the strips are readily available here in Nigeria, distributed nationwide. Then let me move on to the home run products. So for the home run ranges, we have the M1. Good afternoon, distinguished pharmacists. My name is Joy de Malaria. I represent NewHeights Pharmaceutical. So we have 3 portfolio of our products. The first on the list is the health check ranges. So here we have the pregnancy test kits that detect pregnancy as early as 4 days after conception. It is a product of choice when you want to detect HCG. But we also have the PSA test kits that detect prostate-specific antigen. We also have the Triple H viral cassette. It's the first cassette here in Nigeria that detects HIV, hepatitis B and C at the same time with one sample, with a single blood sample, without cross interaction. And then we also have the H. pylori cassette. We have also our BG check machine, a blood glucose meter, and the strips are readily available here in Nigeria, distributed nationwide. Then let me move on to the home run products. So for the home run ranges, we have the M1 Basic. We have the M1 Basic, which is the most affordable product in our ranges, for the home run ranges. So anybody, it is affordable, it is pocket friendly. So no matter how the situation or economic situation in Nigeria, you can afford M1 Basic. It has a large cuff, also like the M3 and in the M6. Then we also have the M6, which is comfortable, actually meant to be used by elderly patients and also pregnant women that does not have a constriction when it's inflating and deflating. The memory is fine. Then the M7 has same cup size with the M6. It's also a product of choice for the elderly, but an additional feature is the IT, which is the Bluetooth device. So you can pair it with your phone and send your result down to your healthcare practitioners. Then we also have the new product online, which is our Omron Complete. Omron Complete has an ECG attached to it. So when you check your blood pressure, you also check your ECG. So it's a product that is a must-do product in your pharmacy space. Then we have the Evolve, it's a tubeless product. Then I move on to the pharma ranges of products. We have the Ephamoibnin Primrose, the Ephamoibnin Primrose. It helps to balance the hormone and glues the skin. We have the brain liquid and the brain capsule for children. We have our new bees in the pharma ranges. We have the amlodipine, we have Cabidilol, we have Losartan, we have PCM suppository. And I promise that when you come to our stand, we have some freebies for you. When you purchase our product, we have freebies to share with you. So I'm inviting everyone to our stand, and I know that you will not regret coming to our stand. Thank you.
Hi. My name is Chizaram, a representative for EMSA Pharmaceutical Industries. So here today we have a lot of product displayed for you. I will be waiting for your patronage. So I'm going to be showing you some of our products we have and some of the promos that are attached to them. So right here is EMSA's brand of Clotrimazole. It's called Clotrivag, 200 milligrams. And there's this particular product, There's this product we are really running a promo on. EMSA's brand of Cefuroxime. It is called Quercetil 500 milligram. This product, we are putting it on a promo. Normally the price is around 3,000 naira, but today we are selling it at the price of 2,800. Now, if you're able to get from 5 packs and above, you are going to be getting a word cloth, and then some other promotional items that are attached. We also have our brand of DHP, EMSA's brand of DHP here, the Hydroartemisinin Peperaquine. Normally it is sold for 1,300, but today we are giving it at a price of 1,100. And then if you're able to get a box of it contains 10 packs. If you're getting up to a box, you also have a gift attached. You get a word cloth, you get all the promotional items attached. So I'll be expecting you. This is our brand of Zolat 400 milligram chewable. It is coated in chocolate. It is very, very delicious. We are bringing in this product. I know a lot of you must have seen it, but it is also on promo. We also have other products. EMSA's brand of Cefixime. It is called Emzifix 400 milligram. It is also on promo. You would like to know that. So we'll be expecting to see you on this stand. Thank you, and thank you very much.
Sarumi. I'm here at the PSN Lagos Pharmacy Week. I'm representative of Get Pharma. I'm at the Get Pharma stand. So we have our brand of product ranges here with me. One of them is Salboget, our brand of salbutamol. So this is actually on a promo. If you buy 10 packs of this, you get 1 pack free. We also have our brand of azithromycin suspension. It's also on a promo. If you buy 10 packs of this, you get 1 pack free. And then we have our brand of Artemether lumefantrine, Ateget EZ. It's also on a promo. If you buy 10 packs of this, you get 2 packs free. And then we have our brand of Getzone Insta as well. This is not actually on a promo, but it's our very unique formulation, omeprazole and sodium bicarbonate. It comes in 40 milligram and 20 milligram, as you can see here. So all these products are available for you. Thank you.
Okay, my name is Mrs. Rito Ojukwu, the Regional Manager of SAM Pharmaceuticals. Today we are here to represent SAM with the ranges of products that we have in display here. I'll start with a brief introduction of each and every one of the products listed here. This is our brand of amlodipine for the management of BP cases. And this is our brand of prednisolone. This is Prednisam by name. This is also our brand of metronidazole tablets, 200 milligram, blister pack, 10 by 10. And this is our beautiful product, Ascovite, chewable and 100 milligram. This is by 1,000. This is our Bicosam.
And these are special products I also want to introduce to the public. These are a brand of diclofenac and paracetamol, Inflanil by name, a product of excellence. This is one of the top-notch products Sun Pharmaceuticals have in store. And these are precious paracetamol 500 milligram blister pack by 96, the red sachets. And this is quality inclined. We are here with quality, we are not here with quantity. If you've come in contact with some products, you know that what we preach is purely quality and not quantity. Then this is our brand of Cotrimazole 480 milligram blister pack 10 by 10. And this is our beautiful brand again of cyproheptadine with multivitamin. This is specially made for the management of cases of children that find it difficult sleeping. This is good for them. This is also good for the management of any kind of any kind of multivitamin management. And this is our brand of Adozi, methyl dopa. Adozi by name 10 by 10 blister pack from Sun Pharmaceuticals. And this is another beautiful product from Sun Pharmaceuticals, Mazeron capsule, our ferrous iron capsule, encapsulated for pregnant, young, old can take this. And these are flagship products, Acipep by name, which is our brand of antacid with anti-reflux action. And this special in the market with the contents that it comes with. Presence of organic acid. And this is the blister pack, the chewable tablet. This is equally very, very special because this is the first of its kind in the market. The only antacid chewable that contains organic acid in the market. And Sam is proudly bringing it to the market with the quality that is inclined. And now to the beautiful products of the day. This is our Facita, our brand of anti-malaria artemether lumenfantrine. We have it in the 8480 and 2120. And a special thing about this product is that, one, the quality that it comes with, and the excellent results we've been getting from our users, our patients and our customers. This is a product of choice for anybody that is interested in first-hand treatment of malaria. Thank you. I remain my humble self, Rita from Sun Pharmaceuticals. And can I?
No.
I wanted to talk about the problem.
We have just a short time to show this thing. And see, the tea break, that's when we're supposed to be showing it. Oh, yeah? Hurry up so that we can show you during the break.
No problem. Is it on?
I thought the man was putting your roll over.
What? Oh, shit.
The Pharmaceutical Manufacturers Group of Manufacturers Association of Nigeria, PMG-MAN, in collaboration with GPE Expo Private Limited, presents the 7th Nigeria Pharma Manufacturers Expo 2024. Theme: 40 Years of Advocacy, fostering partnership and innovation to unlock the pharma manufacturing value chain in Nigeria, Central and West Africa. Keynote address speaker, Professor Padmasri Jan-Sampath, Chief Executive Officer, African Pharmaceutical Technology Foundation, Kigali, Rwanda, and Senior Advisor to the President, African Development Bank, AFDB, Abidjan, Cote d'Ivoire. Special guest of honor, Dr. Tunji Alausa, Honorable Minister of State for Health and Social Welfare, Federal Republic of Nigeria. Chief host, His Excellency, Mr. Babajide Sanwo-Olu, Governor, Lagos State. Host, Oluwatosin Jalayemi Esquire, Chairman, PMG-MAN, CEO Managing Director, Daily Need Industries Limited. Date 4th to 5th September 2024. Venue, the Balmoral Convention Center, Sheraton Hotel, Ikeja, GRA, Lagos, Nigeria. Time 10 a.m. daily. This hybrid event will be streamed live on PharmaStream TV YouTube channel, inclusive of all PMG-MAN platforms. Subscribe to these channels for live notifications. Announcer, Pharmacist Patrick Aja, Chairman, MPME 2024, MD CEO, May and Baker Nigeria PLC. Signed, Pharmacist Frank Mwaneme, Executive Secretary, PMG-MAN. The Pharmaceutical Manufacturers Group of Manufacturers Association of Nigeria, PMG-MAN, in collaboration with GPE Expo Private Limited, presents the 7th Nigeria Pharma Manufacturers Expo 2024. Theme: 40 years of advocacy, fostering partnership and innovation to unlock the pharma manufacturing value chain in Nigeria, Central and West Africa. Keynote address speaker, Professor Padmasri Jan-Sampath, Chief Executive Officer, African Pharmaceutical Technology Foundation, Kigali, Rwanda, and Senior Advisor to the President, African Development Bank, AFDB, Abidjan, Cote d'Ivoire. Special guest of honor, Dr. Tunji Alausa, Honorable Minister of State for Health and Social Welfare, Federal Republic of Nigeria. Chief host, His Excellency, Mr. Babajide Sanwo-Olu, Governor, Lagos State. Host, Oluwatosin Jolayemi Esquire, Chairman, PMG Man, CEO Managing Director, Daily Need Industries Limited. Date 4th to 5th September 2024. Venue, the Balmoral Convention Center, Sheraton Hotel, Ikeja, GRA, Lagos, Nigeria. Time 10 a.m. daily. This hybrid event will be streamed live on PharmaStream TV YouTube channel, inclusive of all PMG Man platforms. Subscribe to these channels for live notifications. Announcer, Pharmacist Patrick Aja, Chairman, MPME 2024, MD CEO, May and Baker Nigeria PLC. Signed, Pharmacist Frank Mwaneme, Executive Secretary, PMG Man.
On behalf of the ESCO member of PSN Lagos, I want to appreciate all my colleagues here for coming for this masterclass. You know, just like the parable in the Bible, you see, there was a man, he wanted to have a feast, and he asked the people to come. When it was time, they could not find anybody. So he had to now tell, okay, go to the streets and bring as many as you can. But to God be the glory. We were not like that. Everybody are here. We are here, colleagues. So I appreciate all of you. I know you are eating, but all of us can give ourselves a round of applause. You know, all of you will agree with me that we have actually learned. Even the one my sister impromptu took, it was a very beautiful session. So let's clap for Pharmacist Adetola. Thank you very much. So tomorrow we'll be having our opening ceremony at Providence Hotel. You know, it's a departure from the Sheraton because we couldn't get that date for Sheraton. We had actually, to tell you the truth, we have actually booked, but maybe some powers that are higher or whatever, they decided to book this whole week in Sheraton, and they said they can't accommodate us for today. So that's why we are moving to Providence. So that's actually the reason. So please, we expect us 9 a.m. at least, red carpet. So that's the chairman of CPC. Let's give a round of applause for pharmacist Derek Osondu. He had actually worked very hard to make sure that all that we are having this week, you know, is beautiful and impactful. So, and on Friday, I always want us to have programs that we will finish on time. If not for Pfizer, we will have even finished before now. So, you can testify to that. So tomorrow, we will start on time and we will finish on time. And on Friday, Como will be having outreach, medical, we always impact people around this area and beyond. They come far and wide to come and enjoy free medical facilities, pharmaceutical care that they couldn't have even enjoyed anywhere. So let's give a round of applause to Como. So all Como should clap, Como members should, and aspiring members of Como should also clap. So we will be expecting all of us, whether you are Como or not, if you can, contribute, maybe bring your BP machines, bring your blood sugar. Okay, we are. And even some extraordinary tests that I will not tell you about will also be, available. So then on Friday, by the grace of God, after Como events will dovetail to what I will call social afternoon, because it's not social night, because we will close by 7:30. We start like 4. It will be here. So it's another, part of the week to socialize and to enjoy ourselves. Anybody if you are around for the February meeting, please raise up your hand for our February meeting. If you witness the way it was organized, it's just going to be similar to that one, but maybe a bit bigger than that. So once again, I want to thank all of you. Then on Saturday, we will have our picnic. So let me hand over to the MC to give the vote of thanks, and maybe then our mommy will pray for the closing prayer. Okay.
Thank you very much. Can we give the chairman a round of applause? At this juncture, I'm also going to thank. He has done the vote of thanks anyway, so that we don't tautologize the event. Tautologize. So we're going to invite our mommy for the closing prayer. Please, it's your house. You can abide here forever. So after closing, you can continue. Thank you.
Praise the Lord. Now let us pray. Our gracious Heavenly Father, we thank you for your mercies, your goodness unto us. We thank you for being there for us all the time. We thank you for counting us worthy to be living souls, even to witness another pharmacy week in the year 2024. Father, Lord, we are grateful. We thank you for the way it has been. Lord, you provided sponsorship here and there. You gave us the strength to be able to come. You gave us the knowledge and understanding. Our brains are not weak. We are able to grasp all that we are taught. And we know that we shall put them to use in Jesus' name. Father, Lord, we thank you. You are the healer of all. Hepatitis, cancer, whatever, all those nonsensical diseases will not reach us in Jesus' name. You will protect us from all troubles, from all disasters in the mighty name of Jesus. And where we need to take care of ourselves, Father, we thank you because even before we get there, you will be there for us. And you will facilitate the healing, firstly, to the glory of your name in Jesus' name. Father, Lord, we pray that even as you are with us today, you will continue to be with us until the end of time. If Jesus tarries, we will be here next year celebrating 2025 Pharmacy Week. And it shall be well with each and every one of us in Jesus' name. Above all, Father, give us the opportunity to have eternity with you in the mighty name of Jesus. We will not walk in vain. It shall be well with us. We shall make it at the end, strong and well, in Jesus' name. Thank you, Heavenly Father. Blessed be your name, O Lord. For in Jesus' name we have prayed. Amen.
So, once again, I say thank you to every one of us. So, let me tell you also that there were over 200 colleagues online. So, they attended the something program virtually. So that's a nice one also. Yes.
Pharmaceutical Society of Nigeria, PSN Lagos State Branch presents the Annual Pharmacy and Scientific Week 2024. Theme: The Imperatives of the March Towards Achieving Universal Health Coverage in Nigeria. Chairman of the occasion, Pharmacist Victor Afolabi, MD Wellness HMO. Keynote address, Pharmacist Kunle Tometi, FPSN, President of Nigeria Association of Pharmacists and Pharmaceutical Scientists in the Americas, NAPSA. Chief host, Professor Cyril Usifo, President, Pharmaceutical Society of Nigeria. Host, Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Pfizer Pharmaceuticals, Greenlife Pharmaceuticals Limited, and NewHeights Pharma. Starts 9 a.m. prompt on Wednesday, 28 August 2024 at the PSN Lagos Secretariat, Ogudu, Lagos, for both physical and virtual attendees. Grand opening ceremony date Thursday 29th August 2024. Venue Providence Hotel, Obaki-W Way, Ikeja. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be streamed live on PharmaStream TV YouTube channel. Subscribe today for instant notifications when event goes live. Announcer Pharmacist Derek Osondo, Chairman, Planning Committee.